We recognize the contributions of our keynote speaker, Dr. Jacqueline Whittle, Mistress Mary Lise Smith, presenter and representative from Kettering Health, Mrs. Carol Williams, who will be doing our devotional thoughts, and our other presenters. To all our viewers, be it on the platform of Zoom or on YouTube, we want to say how much we appreciate you being with us today. Students, we greet you, student. So she will bring the formal welcome to you.
Eternal Father, bless our land, guard us with thy mighty hand, keep us free from evil powers, be our light through countless hours. To our leaders, great defender, grant true wisdom from above. Justice, truth be ours forever. Jamaica, land we love. Jamaica, 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 land we love. Teach us true respect for all, stir response to duty's call, strengthen us the weak to cherish, give us vision lest we perish, knowledge send us true wisdom from above, justice, truth be ours forever. Jamaica, land we love. Jamaica, 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 land we love.
We interrupt this program to bring you breaking news. To our keynote speaker, dignitaries, other members of the faculty, and viewers, we advise that you brace yourself for this mammoth task ahead as we highlight and resolve this medical conundrum. I am Natron Lawson, reporting live from NCU Hospital, Chamber of Nursing, where our preoccupation is not only scientific diagnosis, but also societal. Word has been coming in off the street, stating that an arduous group of nurses inherited the tumultuous task of conducting a health assessment on a particular settlement in our society. Having compared the circumstances of the community to the requirements expected to guarantee societal health within that area, the group was left appalled at the lack of qualifications. Though convoluted that task, the unit deduced that this settlement was deficient as it lacked the economic vitamins needed to promote proper societal functioning. In order to restore the health and vitality of this resource-sick territory, our goal, yes, we changed the direction as the solution was now a societal intervention. The cure to this disease needed no contemplation nor speculation, as the ideal cure was education. And ladies and gentlemen, to those tuned in online, we welcome you to this momentous occasion as we operate under the banner Informing the Trajectory of Nursing in the 21st Century and Beyond. Here, we will debunk theories and promulgate the right path in becoming nursing official in this generation and beyond. For those of you who could not be on ward with us physically, we appreciate your virtual presence. Sit back, relax, as you witness various examinations being undertaken by our highly qualified expert nurses throughout the course of this program. I can assure you that their presentations will disrupt the equilibrium to successfully sensitize us of the multiplicity of methods to cure the warped perspectives of nursing. Additionally, they will aid in restoring the societal status and integrity of this field in these unprecedented times. For safety purposes, as you venture on this journey, please be advised to wear your PPE, as we will be navigating uncharted territory. Matron Lawson reporting live at NCU Hospital. If you are tuning in from yard or all the way abroad, we want to say welcome. I hope you feel the warmth to our Nursing Research Conference. We are identifying problems. Now that's assessment. We are diagnosing and we plan to solve them. Solving them would be an implementation. We would love to hear your review after an evaluation. What is nursing? Without a care plan, let us inform and take this above and beyond.
Good. Zaria Lawson, our senior nursing student, for that very creative welcome. So at this time, we will turn our focus to our spiritual emphasis, which will be done by Mrs. Carol Williams. Permit me to tell you a little bit about her before she does her presentation. Mrs. Williams was born in Trelawney, Jamaica. She migrated with her parents to the Cayman Islands during childhood. She graduated from the nursing department of Northern Caribbean University, formerly West Indies College, in 1988, and has served in various capacities as a nurse. She worked at the Cayman Islands Hospital, Port Antonio Health Center, College of Agriculture and Science and Education, the Dunoon Technical High School, Innswood High School, and as nurse manager for the Concy Walters Cancer Hospice. Carol also worked at the Dial Life Insurance Company, First Life Insurance Company, and the Life of Jamaica Insurance Company as their company nurse. Mrs. Williams has a master's degree in marriage and family therapy from Liberty University School of Behavioral Sciences and currently works as a case manager for behavioral/mental health with Managed Care Concepts, Boca Raton, Florida. She is the author of the devotional, When God Says, I Will. It has been definitely an inspiration to many. Mrs. Williams is married to Pastor George Williams, and they currently serve in the Florida Conference of Seventh-day Adventists. They have one son, Roger George, who is a commercial pilot as well as a
UK registered nurse, did a doctoral study on the subject. And she said in her article titled, The Spiritual Dimension, Its Importance to Patients' Health, Well-being and Quality of Life, and its implications for nurses. And she wrote, quote, "Interest in the subject of spiritual care was stimulated following an encounter with a terminally ill patient. Having been asked if she would like a passage read to her from the Bible, which was located on her locker, the change in this woman's expression was remarkable. Instead of lying, sleeping, or staring blankly into space, her eyes widened. She strained to raise her head. She smiled. She attempted to speak for the first time in several months. Later, just before she passed, she expressed how much this, together with prayer, had meant to her." End quote. You see, this woman, as a patient, had a spiritual need that she wanted met. I further quote this author. "This profound and moving experience suggested that the spiritual dimension could have considerable influence on a patient's quality of life." End quote. This author stated that it was the desire to discover more about the relationship between the spiritual dimension and the individual's health potential that the literature was reviewing. 2 out of 3 nurses said they felt stressed about their jobs. Mental Health America in 2021 found that 41% of nurses reported experiencing high exposure to COVID-19. The American Nurses Foundation in 2020 found that high numbers of nurses reported feelings of being overwhelmed, 51%, anxious and depressed, 48%, feeling irritable, 48%. Also, 3 out of 5 reported difficulty sleeping in the midst of the pandemic. That might seem like all bad news, but there is some good news, because in 2021, the Gallup poll on professions found that nursing remains the most honest, ethical, and trustworthy profession. Nurses are still loved and respected, and may I say that for the 20 years that this poll was being conducted, nurses were on top in 19 years, and that's extraordinary. Now, considering the aforementioned, there is a need for the spiritual aspect, the underestimated dimension, which often is thought about as a last resort. Spiritual health has attracted a lot of attention in health-related and nursing sciences, and also numerous researches. And according to Jaberi et al. 2019, the results of a concept analysis research on spiritual health found that, for the most part, well-being and, yes, moral development were the outcomes of spiritual health. Now, nurses play a significant role in their patients' spirituality, and there are implications of meeting and also failing to meet these needs. When these spiritual needs are identified and appropriate actions are taken, there's a possibility that stress is removed, which can have an effect on the physiological, social, psychological, and spiritual well-being. Barriers to recovery are removed, and they ultimately can experience optimum recovery. L. Ross. Let's now take a look at the important aspect of prayer. According to Jantos and Keats in Prayer as Medicine, How Much Have We Learned? They said, many people use prayer, and some studies have shown a positive association between prayer and improved health outcomes. They further stated that this should be reflected in patient care. They further stated that although chaplains and pastors and priests and so on are qualified to address patients' spiritual concerns, other professionals, including, yes, doctors and nurses, should also be willing to participate. And I could go on and on and on about the various research that will, talk about the importance of prayer. But on the evening of February 6, 2022, CNN featured a woman in Texas, US, who was pregnant and had a heart attack and also a stroke in what they refer to as an epic COVID-19 battle. She was hospitalized for a total of 139 days. The good news, however, is that the baby was successfully delivered, and both baby and mother are doing well. Now, I was intrigued when they asked her husband what kept him going through all of this. He said, and I quote, "It was prayer. I prayed a lot during all of this," end quote. And the doctor, one of the doctors involved in her care, he concurred, and he said, and I quote, "Yes, a lot of prayers went up, and that helped a lot," end quote. Man is a composite being, multi-dimensional. But the facet that is often neglected is the spiritual dimension. But there comes a time when the limitations of medical science becomes evident, as we're seeing right now. But as nurses, the context in which you operate affords you the opportunity to provide that underestimated aspect of spiritual care. As stated previously, research has proven that individuals who have a spiritual connection do better in the coping and recovery process than those who do not. This effect has not even been fully explained. It can hardly be. It is mystical, but yet very real. God created man, and he invested a portion of himself in man when he blew the breath of life into man. And it is this God consciousness or God awareness that is often missing. The knowledge that one is not alone during pain and suffering, but has an unseen companion, can become a support structure that one can lean on. Of course, much research needs to be done on this underestimated dimension. And so I challenge you nurses, whether you're a student or you are a well-experienced nurse, that you will consider this very vital subject. Because you know what? You will certainly inform the trajectory of nursing in the 21st century and beyond. Now, to wrap up this presentation, I would like to share a devotional thought with you. On my last 3 flights on a trip I took 2 weeks ago, I listened to the flight attendants giving the flight safety instructions. And I have to confess that for the most part, I don't usually pay attention because, you tell yourself that you've heard this so many times before. But for some reason, there were 10 words that caught my attention. 10 words. In explaining how to put on the mask in case it was necessary, the flight attendant said, and I quote, 10 words. Be sure to secure your own mask before assisting others, end quote. Nurses, you must take care of your own spirituality before you even consider helping your patients with theirs. You see, you cannot serve from an empty container. You cannot give what you do not have. Do not underestimate the power of spirituality in your own life. Do not underestimate the power of prayer in your own life. This might sound ridiculous, but don't show up at your patient's bedside with an empty syringe to administer an IM medication. No. And worse, do not show up spiritually empty. And so, I have rewritten the instructions from those flight attendants. Listen to the new instruction. Nurses, be sure to secure your own spirituality before assisting others. I know that we are living in very challenging times. And the truth is, we do not know what the future holds. We do not know if things will get better or get worse. But whatever nursing capacity you occupy at this time, I want to encourage you to believe that God is faithful and will forever remain faithful. One of my favorite Bible verses is Isaiah 41 verse 10. And in this one verse, God made not one, not two, but 3 promises. It says, "Fear thou not, for I am with thee. Be not dismayed, for I am thy God. I will strengthen thee, yea, I will help thee, yea, I will uphold thee with the right hand of my righteousness." And I kind of like the third one, I will uphold you, because my understanding is that in the Hebrew language, the right side means strength and might. Nurses, God has promised to hold you, to carry you, to lift you up. And to borrow the words of Bobby Mason song, pray on, for you are who the Lord is looking for. Pray on, for this will tear those mighty strongholds down. Stay on your knees, for this is where the battle is won. Very soon, you'll win the victory. Pray on. And nurses, if you look after your own spirituality, if you pray and pray and pray, you will inform the trajectory of nursing, not just in Jamaica, not just in the United States, or wherever you practice, and not just in the 21st century, but beyond. Shall we pray? Heavenly Father, I thank you for calling nurses for such a time as this. May you grant them all they will need to be their best. May you fill their cups, Lord, so they will have to share. Provide for their spiritual needs, their physical needs, their financial needs, whatever it may be, provide for them, Father. Please bless the remainder of this symposium. Bless all those who will participate. May it be a resounding success, and may your name be honored and glorified. I pray in Jesus' name, amen. May God bless you. May God bless all of you.
Praises hymn number 44, Morning Has Broken. Morning has broken like the first morning. Blackbird has spoken like the first bird. Praise for the singing, praise for the morning, praise for the springing, fresh from the word. Mine is the sunlight, mine is the morning, born of the one light, Eden saw play. Praise with elation, praise every morning, God's recreation of the new day. Praise with elation, praise every morning, God's recreation of the new day.
Amen, amen, amen. We see the responses in the chat. We want to thank our sophomore nursing student, Miss L'Oreal Sharp, for that rendition. And we will consider the words of our devotional thought. Powerful thoughts, powerful, powerful. So at this time, we're going to be having our greetings. We will first have Mrs. Juliet Poiser, our assistant professor, acting director of nursing, followed by an alumna from the nursing department, Dr. Glenda K. Caballero.
Good morning. Good morning, everyone. Okay. All right, thank you. Good morning, everyone. Dr. Lincoln Edwards, President of Northern Caribbean University, Dr. Vivian Quarry, Vice President of Academic Administration, Northern Caribbean University, Professor Vincent Wright, Dean, College of Natural and Applied Sciences, Allied Health and Nursing, Northern Caribbean University, Dr. Mrs. Carol Williams. I really appreciated what you just did, case manager for behavioral mental health, managed care concepts, Boca Raton, Florida. Thank you. Administrators, faculty, staff, and students of Northern Caribbean University, friends, parents, family members, ladies and gentlemen, good morning. I would like to welcome sorry about that. I would like to add my welcome to everyone for attending this portion of the nursing portion of the research symposium. We all know how important research is to all professions and that there's a dearth of research in nursing. So we are proud to acknowledge that with the support of Mr. Bourne, Dr. Mclean, the nursing students and others, the nursing department has published more than a dozen research articles. I'd like to also at this time thank Miss Graham and the research committee for all their hard work. It took a lot for them to put this together. Please sit back, relax, and enjoy this educational opportunity. Thank you.
Nursing class of 2011. Hi Nursing Research Conference of 2022. I am Dr. Glenda K. Caballero, and I bring greetings from the nursing class of 2011. Yes, I did nursing at the Northern Caribbean University, and boy, was it a journey. I'm so happy to be a proud graduate of the best nursing program that exists. And I'm sure you are learning a lot. NCU has done a great service in shaping the minds and lives of the future of medical care. As we ride this global pandemic that is COVID-19, we are the movers and shakers and the heroes that really come together and build and fight against this pandemic. Now, to be a part of the NCU experience, it is a great honor. And while nursing may be one of the hardest degrees, with all the ups and downs and turmoil and fighting and crying and studying, I am proud that there are so many skills that I could have benefited from while doing nursing that I still use today as a doctor. And while working with my nursing colleagues, I feel so much honor. I feel so much pride. And I'm sure that you have a lot to learn and a lot to gain from being a part of this conference, being a part of this experience. And I'm so happy that you invited me to give greetings on behalf of my class. So again, on behalf of the nursing class of 2011, we are proud to say greetings, have fun, learn a lot, and ensure that you know that you are shaping the future of tomorrow. Thank you.
I think Davis will introduce our guest, our keynote speaker.
I am here. The path for her journey began at a young age when she came from Jamaica, West Indies, to be with her family in New York. She is the last of 11 children. Although she had to leave her birthplace, she did not depart from her upbringing with strong moral principles, cultural values, beliefs, and the love for her Jamaican patois. Dr. Whittle is currently employed at St. Barnabas Health Systems, Bronx, New York, as the Vice President for Nursing Quality and Nursing Informatics. She was featured in the Crane's Business Journal, May 14, 2020. Dr. Whitters is guided by strong ethical principles. Her personal and professional mantra: keep the patient first, treat patients and their families the way you expect to be treated. She is an active member of Sister Callista Roy's Association and values all opportunity to integrate Roy's conceptual framework into academia and practice. Dr. Whittle has received numerous awards for nursing leadership, education, and research. She is known nationally and internationally for her professional presentations on nurse practice roles and transition of care. You are not alone. Roles of the caregivers. Publication on mentoring for novice medical surgical nurses in an acute care hospital. Bullying in practice, academia, and law. She is a lifelong mentor and is proud to give back to the nursing profession and to society. Dr. Whittle provides humanitarian support not only to her community, but also to other countries. Ladies and gentlemen, help me welcome the 2022 keynote speaker to the Nursing Research Symposium, Dr. Jacqueline Whittle. I thank you.
Video off.
Good morning, Jamaica. Ms. Thompson, I thank you for that warm welcome. I want to say good morning to my fellow Jamaicans, to all the leaders, faculty members, administrators, family members, students, and friends. I am honored to be the keynote speaker for Northern Caribbean University. Next, I have to advance my slide. Okay. Are they able to see this? Okay. Presentation mode.
And you have to remember
wait,
that part of the presentation is also the source road. So you have to be very...
Video.
Huh?
Just press stop video.
Stop video. Okay. Sorry, one moment.
And I should be able to see it.
Can you see it? No.
Yes, we are seeing.
Are you seeing my slides?
Yes, we are.
Which one, sweetie?
This one here. Oh, sorry.
Okay, hold on.
On here.
This one?
Mm-hmm.
Slideshow?
Yeah.
Okay. No, it's not going. Can you see it now? Ah. us to feel secure and unashamed in terms of who we are, and the realization that mental illness can happen to anyone and at any time. I'm not advancing now.
Oh, right, sorry.
Okay, I need you to help me. Okay. Sure. So my introduction, mental illness and wellness need to be woven into discussions and how to mainstream the need for advocacy, resolutions, and attracting the much needed economic support. Mental illness is an integral part of health. Human beings, we deserve an environment that respects and protects their basic civil, political, and socioeconomic and cultural rights. Significant gap is taking place globally between mental illnesses and mental health services. We have stigma, we have discrimination, and human rights abuse of our people with mental health conditions. And this is widespread. I wanted to give you some conceptual definitions of mental health and mental wellness so we understand the gamut of mental illness. According to the World Health Organization, right? They define mental health as the state of complete physical, mental, social well-being, not merely the absence of a disease. Health is global and wellness is an active process that we all must be involved in and we all must contribute to achieve. Wellness is the optimal state of health of all individuals and all groups. Wellness is holistic. We can't just treat one part. We gotta treat from a holistic and a multidimensional as physical, intellectual, emotional, environmental, social, and let's not forget spiritual. Good mental health and well-being they're essential components for us to lead fulfilling lives and to contribute productively to our communities and to society at large. A state of well-being in which the individual realizes or not realizes their own abilities. That's mental health. That they can cope with the normal stresses of life, to work productively and to contribute to society. Let us turn and look what's happening with the COVID-19. People have a lot of stressors and they're unable to cope. Coping mechanism is not there, but we must support and create that forum for this to take place. Mental illness is a leading cause of disability worldwide. Look at the contributing cost at the global economy level, $1 trillion each year. Is this frightening? It's real. Prevention, early intervention, and the recovery for public health must be a priority in all our levels, must be. 80% of worldwide people with mental illnesses, they reside in low socioeconomic and low income brackets, and these are globally. 90% of the people with mental illnesses, they do not have access to evidence-based care, right? What are some of the factors that are associated with this? Disparities, stigma, social poverty, unemployment, and homelessness. People are homeless. People who had jobs, people who were able to function in their communities, we see them, they're homeless. They're homeless. Depression and anxiety, they are the two most common mental health disorders. I want to give you the stats for us to have a better understanding and appreciation of what needs to be done for mental illness. People with severe mental disorders, schizophrenia, they tend to die 10 to 20 years earlier than general population. Suicide is on the rise and is the fourth leading cause of death for young people ages 15 to 29 years old. It is all over that people are taking their lives. Globally, the COVID-19 pandemic has had some major impact on people's mental health. Not only our frontline workers, but for our students. And I know a lot of students, you're listening to me. Take heart. Go out there. Become who you are and what you want to achieve. Yes, you're going to be afraid, but we all have done it. You can do this. Take courage. Take heed. You are the future for us. And leaders, colleagues, let us support those students who are coming out. Let's stop eating our young. I don't want to hear this over and over in literature that in nursing, we are eating our young. We got to look at people living alone, people with pre-existing medical and mental conditions. It's real. Now let's turn to Jamaica. And I have to look up the stats for Jamaica. After all, I'm talking to my Jamaicans and people throughout the world. Mental illness is burdensome, right? I hate to use this word burdensome, but it is on individuals, families, society, and economy. Our caregivers who are taking care of loved ones, it's very hard on them, very hard. Mental illness is also described as a global health and developmental priority. It has to be. It has to be a priority. Anxiety, depression, psychosis. Psychosis is a classified term, schizophrenia and things like that. I'm not a psychiatrist, so I didn't want to go into the different terms, but psychosis are the three common mental illnesses in Jamaica. It really, we got to look at psychosis in terms of the it's responsible for 106,664 patients who come to clinics, for treatment. 3% suffer from depression, 4% from anxiety, 80% they have psychosis. Women have higher rates of depression and anxiety than men. Now, I don't want to sound like a sexism or a sexist person, so to speak, but why women? All right, we're not going to take a debate on that. Anxiety disorders are seen in 20 to 34-year-old, 30 to 59 years old, women at risk for both depression and depression has 3.7 and 4.7 for anxiety, and men with 2.3% for both. But the good news is, first, it would be very remiss of me not to mention two noted psychiatrists on the Jamaica landscape. The late Dr. Fred Hicklin and Dr. Wendell Abel, amongst others. I saw in the literature that Jamaica has multi-sectoral task forces that are going out to the communities, expanding mental health training for healthcare workers, which is good. They're looking at homelessness. They're looking at rehabilitation. That's what we need in the communities. And the Ministry of Health, they're the ones who are ensuring that this is taking place. So Jamaica, I commend you. You do have programs. You're looking at what's happening globally, but also what's happening in Jamaica. As I go on, I want to talk about social determinants, social factors, socio-economic barriers for our people. The sexual violence, sexual abuse, child abuse, social changes, the right of human beings, discrimination on all levels, inequality. What is right for one person must be right for the others. This is such disparities, social exclusion, and human rights violation. So what are the social changes? Cost of living, everything gone up, all right? Everything is up. Stressful work environments. Talk about having to work sometimes remotely, locked in a room. I like to be out there. I wish I was in Jamaica at the podium. You had a whole basket of mangoes waiting for me in the background, and that I could talk to my people. I can hug my people. But I can't. I can't because of the COVID. Others have stressful situation. They have lost their job. They have lost their loved ones due to COVID, right? Unemployment is so real. People are lining up. People are saying, I will take this job regardless of a title because I want to work. Unhealthy lifestyle. People cannot afford, the ritzy life. They can't afford, the nice steaks if you eat steaks. The nice, cut the steaks, the nice vegetables. Some people can't. I'm talking globally. And of course, disasters. But COVID-19, the pandemic, we have such fear factors contributing to the virus. Who wants to get this? Nobody wants to get this virus and die. We have seen so many deaths. I share with you the first pandemic. I heard so many codes overhead that it was ringing in my ears every time I left that hospital. And I was not sitting in my office. I was on the floors with the nurses, supporting them, praying with them, singing with them, and of course, taking care of our patients. Changes to our daily lives. And I spoke already about restrictions, what we can do and what we can't do. Sometimes we get a little angry, right? When lawmakers say what we must do and can't do, and we have to listen to the scientists, right? Not the politics that's involved with this. You just have to say this. I'm not a politician, okay? Realities of working and schooling your children, that socialization, your kids can't run outside and play with the dice and do the skipping and things like that. Fun memories when I was growing up in Jamaica. Restricted visitation to our health institutions. You can't see your loved one. You can't go sit and bring them a meal into the hospital, right? You can't hold their hands, pray with them, and give that support that they need while they're in these institutions. That is a big factor. How do you tell your loved ones? You can't see that person, but the person is dying. You talk about human touch nurses. This is what we are faced with. We become the caregivers, the healers, promoting what we can do best, what we set out in nursing to do. Do no wrong, do no harm, and that we care. Florence Nightingale, Mary C. Cole, must be turning in their graves and saying, carry on, nurses, carry on. Mental stigmas. We got to stamp these out. It is one of the global mental health care gaps. It manifests itself between cultures and contexts and supporting groups. The stigmas exist. It contributes to worsening of disabilities through the loss of social and economic opportunities, disadvantages across the multiple personal and professional life domains. It may limit and marginalize the opportunities for the general population. Societal level factors, cultural norms, and institutional policies impact how people with mental health, how they seek care or not seek care. Mental health stigma is identified as one of the key underlying drivers for global mental health care gaps, and it has detrimental effects. Mental health stigma contributes to increase symptom severity of individuals that are living with mental illness. It prevents individuals from seeking the care and the treatment, and this leads to lower self-esteem, anger, and resentment. All right, let's turn and look at contributors to mental health gap. We said stigma. You know, sometimes we say culturally, this a person don't care. For those who don't understand, it means don't care. So what are we saying? We're bringing on shame, low priority, so we silence people. Misinformation, which leads to human rights abuses, discrimination, and reluctance. We don't want to tell anybody we have this, to seek help, right? Negative attitudes that leads to mistrust. Competing demands and poor quality healthcare and poor outcomes. Mental illness is seen like a taboo. We're not supposed to tell anybody with secrets. We must keep it home. We must walk on one side of the road because we dare not have the neighbor. You know, some people are nosy, and it's global. It's not only in Jamaica. Some people, when we say fast, how come I don't see this and that? And we don't want to share because we were told it's a taboo. Let's not tell people with business. Keep it to ourselves. So the help that we need, we can't get it because we are not willing to share. Some cultural myths about mental illness. You ever hear? The head not good, the head not good. It's a family curse. It's caused by evildoers. I'm talking about the obia business. The obia. Children don't experience mental health illness. People can't work. People with mental health can stop out of it. No, no, no. Impossible to prevent mental illness. And mental health issues never improve. Those are the myths. You know differently. Let's leverage, I call this slide, leveraging the playing field. Call to action. All right. So we have implemented strategies. We need more to promote the well-being, to prevention is the key, mental disorders, and promote whatever we do, promote human rights. Let's strengthen the effective leadership and governance of mental health. Let's provide comprehensive services in the community-based settings, and let's make sure everybody knows what's available. Equal rights. Create a healthy work environment to support mental wellness. I'm going to share with you part of one of my roles at a previous place. I had to lead a support group with a team of psychiatrists. And from that, we had many sessions. And the nursing staff would call in like three times a day, different groups. And we bonded so well. From that, we have a published cookbook. So when things happen, look for the positive. Look what you can strive on. It's not always the negative. How can we support each other during these times of crisis? That's leverage the playing field. We want to provide service and programs. Start with the youths and the caregivers. They need help. Procure and ensure the availability of resources. Let politics not get in the way for anyone to give them the needed services. Foster and support and empower. Everybody say we are empowering. Are we really empowering our people? Let's stop using fancy words. Let's start more action, especially when it comes on to mental disorders, families, and caregivers. Students, I'm talking to you, also students. Let's strengthen the information system. What do we have? Look at the platform that we have right now, right? This is on YouTube. Everybody's listening to this crazy keynote speaker. We're sharing information, right? And technology is at its best. But we see the need for technology also during this pandemic. How do you communicate? How do loved ones communicate with their family members in the hospital? Stories being shared, nurses using their own personal phone, and the doctors to link family members with the patient, the dying patient, to let them have that last right to say, I love you. We also must strengthen research for mental health, cultivate recovery-oriented and culturally appropriate care, allocate budgetary means across all relevant sectors. So, my slide, we are all speaking, but are we listening? We need intersectorial strategic approach from a collaborative perspective to master the complexity of healthcare determinants. It is difficult for one institution to impact any changes. It needs to be collaborative across all different specialties. Everybody needs to be on the same page. And we must have the common purpose and for the greater good. For the greater good. Mental awareness and readiness in school-based programs. We need more. Clinics, workplaces, criminal justice systems. Yes, we got to infiltrate and go in and provide the care within criminal justice system. They too have mental illnesses. We have to proactively identify and provide appropriate support for the individuals, right? The risk for mental illness, and for those who have poor access to services. Can I get an amen on that? That we will continue to do that, my fellow Jamaicans.
Amen.
Thank you. Paving the way, informing the future. Recognition, this is what we are doing. Prevention and treatment of mental illness need to be continued. We said it. I've been saying this. It's woven in my presentation. Mental healthness is a part of the recovery strategy, right? Commitment towards a recovery approach in mental health with the self. First, you have to help yourself. Self-management and mutual support. Implication for self-management with potential benefits to foster that patient-led, patient-centered care and make that a part of our planning strategies. Explicit attention to equity. Now, I know students might be saying, but this lady said equity. I'm sure if I was in the podium, you said, Miss, you said equity about 3 times. I'm saying it because it's so relevant. My young people, future nurses. Respect for the inherent dignity and human rights of people with mental disorders and the psychosocial disabilities. Protect our vulnerable and marginalized groups. Please. Paving the way forward. Commitment and accountability for providing quality care for our people. Our people. Let's start at home first, our people. Let's start in our yard first before we go out there. Leaders must eradicate any ideology towards unfair biases or treatment for our people. Faculty members, my message to you, afford these students with the needed knowledge to be able to transform and become the beacon of hope and to influence changes. Give the students what they need. We don't hold back, right? Knowledge is powerful. And what the students do with it, then students, that's going to be your responsibility. You must remain professional and be committed to do no harm. Students, don't be afraid. We all went through different things in our lives. We have been there. Some say we have done that. But some of us forget what we went through in nursing schools and to take our exams, how quickly we forget. And then we turn around. When I was a nurse, what year was that? What year was that? Look at what's happening and give our students what they need. Students, you're going to be afraid going out there. Look how many things happening. But guess what? You have chosen a noble profession. Go out there and contribute to this profession, nursing profession. Contribute. I'm sorry. I'm sorry.
Sorry about that.
Okay, that's all right. This person wanted to say, I think she was saying amen. All right. You know, the pandemic, you might be afraid, students, but make sure that you arm yourself with everything that you were taught and that you're practicing in a team atmosphere. It is not my patient, it's our patient. If you foster that relationship, you will succeed. But if you come out like a peacock, oh, I know this, I know that, I don't have to do this, no, then you're not going to do so well. Parents, guardians, siblings, the movement starts from home to instill fundamental values and expectations for our youths, for the children, for the young people. Starts at home, starts at home. My last slide, conclusion. Now, I wanted to end with this. I know this was sung in the beginning. I won't try to sing because then everybody would click off. So I use certain excerpts. Eternal Father, bless our land. Guard us with thy mighty hand. Keep us free from evil powers. Teach us true respect for all. Steer response to duty's call. Strengthen us, the weak to cherish. Give us vision, lest we perish. Knowledge, send us, Heavenly Father. Grant true wisdom from above. Justice, truth be ours forever. Jamaica, land we love. Jamaica, 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 land we love. Thank you. Any questions, please? Thank you. Thank you.
Any questions for our guest speaker? What an awesome presentation. I saw the chat lighting up and everyone is just agreeing that this is an incredible presentation. So I'm not seeing any questions. So in the interest of time, we're going to go to 2 short videos and then we'll have the poetic expression from one of our nursing students. We just need to give her the time to express herself. Over
you again. Thank you. And Ms. Bryan, I want to say thanks for connecting with me. I found out you're from St. Elizabeth. Folks, I'm from St. Elizabeth. All parishes are great, but I got to big up St. Bess. I got to big up St. Bess. Thanks a lot. Thanks to each and every one. Take care. Thank you.
You're welcome. You're welcome. I'll pass
I
on
want to
that
be
to Ms. Braham.
Northern Caribbean University is a liberal arts values-based institution with its main campus in Mandeville, Jamaica. Founded more than a century ago as the West Indian Training School, the institution has achieved many milestones and has demonstrated a capacity to be innovative and inventive. An example of NCU's innovativeness is placing third in the Microsoft Imagine Cup, where a team from the university represented Jamaica in 2007. In 2010, the NCU team won the Microsoft Imagine Cup interoperability competition on behalf of Jamaica. We have also excelled in the National Business Model competition put on by the Development Bank of Jamaica and supported by the Inter-American Development Bank. Since its inception in 2014, a slew of teams from NCU has performed outstandingly in the competition. In 2014, Team Herbu from NCU created a hair and skincare line from all natural ingredients that combats numerous scalp, hair, and skin issues. In 2015, the NCU team, Jargrow, won the competition with their smart farm system that enabled individuals to plant fruits in their kitchen with little or no hassle. In 2016, Team Gardana won the competition, followed by Natsima Nutraceuticals in 2017. In 2018, after placing fourth in the National Business Model competition, Team Base Tech from NCU went on to win the International Business Model competition held in the United States, making them the first Caribbean and Black team to take home the trophy. Team NCU shone once again during our participation in the Girls in ICT Caribbean Hackathon since its inception. In 2017 and 2018, we placed first, and in 2019, we placed second, missing the first place by less than 1 point. NCU students have also excelled in local science competitions, as evidenced by the achievement of the most outstanding school in the tertiary category in the National Science and Technology Fair 2018. In the area of communication technology, the university is proud of the achievements of its media group. Its flagship NCU FM is now ranked number 7 out of almost 30 radio stations in the country in terms of listenership. It was also the first radio station to bring a wellness campaign to all 14 parishes, the 14 in 14 initiative, which started in 2014. NCU FM is also doing its part in shaping the minds of our nation's children through the Acts of Kindness school tour. The campaign has influenced schools to start kindness clubs. It has also had a positive influence on behavior modification among children across the island and has in some cases even changed the way teachers now administer discipline for wrongdoing. In recent times, Jamaica has been undergoing severe drought due to global warming. Northern Caribbean University is playing its part in alleviating the effects of drought by harvesting rainwater for use on its campus. NCU understands the need for an educated nation, and although the university has tremendous challenges, it is now focused on making education accessible. Through the Rescue 2020 and SOS initiatives, the university administration is seeking to attract funds to assist at-risk and economically disadvantaged youths to access higher education at this institution.
We'll be having a video at this time from Kettering Health, followed by our poetic expression by Shauna K. Spence, a junior nursing student.
To those who are fearless,
who show up and give 100%,
who endlessly strive to raise the bar.
You define what it means to be your best. Here at Kettering, we lead by example.
Investing in each other, our community, and family.
And we know that when we strive to do our best work,
we can impact the lives of our patients and also our own people.
So do you.
The innovative.
The dedicated.
The collaborative.
The compassionate.
We invite you to be your best at Kettering.
I want to share a story with you about a recent rounding I had at work here a few weeks ago. Rounding on patients is one of my favorite things to do, and this day turned out to be no exception. Walked into a patient's room, and she lit up when she saw me and the nurse manager walk in the room. And she said, "I'm so glad you're here." She showed me her lab. Her lab was full of 8 different Daisy Award nominations. And I was like, oh my goodness, that's like a lot of work to fill those out. Tell me about your experience here. And she said, this is my very first time in a Kettering hospital. And she's like, I usually go to the hospital across town. And she's like, I will never go across town. Kettering is now my hospital of choice. She said, all 8 of these individuals deserve the Daisy Award and so much more. She's like, last night I had a nurse named Dorcas. She's like, Dorcas walked into my room and I'm crying. And she walks over to me, she puts her hand on my back, and she said, what's wrong? The patient said she started to tell her story, her situation with her diagnosis, her financial strain, just everything going on, just crushing her at that moment. She said Dorcas pulled up a chair, acted like she had all the time in the world, which you and I know that probably wasn't the case. She sat down, she listened, and she let this lady cry. A few minutes later, this patient told me, Dorcas said, is it okay if I pray for you? And the lady just lit up her face, and she's like, I love that you not only allow people to pray for you, that you encourage it. She said she prayed a beautiful prayer for me, for healing and for hope. And at the very end, she's like, Dorcas then said, would you like me to show you how to download the Bible app on your phone so you can listen to scripture while you fall asleep? Many of you know the story in the Bible about Dorcas in chapter 9 of Acts. Dorcas, when you open that part of the passage, it talks about her great works. She's known for kindness and going and helping those in need. In that story in Acts 9, Dorcas unfortunately passes away. They call Peter, who comes, brings her back to life. And at the end of that scripture, it talks about how so many believed because of that great works. I think about Dorcas working in our hospitals across our network, who each and every night have an opportunity to show that mission, to show that kindness, and to really go above and beyond and help people in need. I know Dorcas did that for this patient on that night. At her lowest point, Dorcas filled that vessel, that need for that patient in that moment. My prayer for each one of us as we go and do our work each day is that we have the heart of Dorcas, that we are known for our good works, that we are known for our kindness, and that at those moments we stop, we hold the hand, we wipe tears, and that we pray with them. Thank you.
Hello everyone, my name is Shauna K. Spence, a junior nursing student of the Northern Caribbean University. Today, I'll be sharing a poem with you that I wrote in light of the COVID-19 pandemic from a nursing student's perspective. They say, live your best life like there's no tomorrow. Eat, drink, sleep, travel, but never forget that in the midst of fun, there's sometimes sorrow. It is at that time that you look back and have regrets. Who said university would be a bed of roses? Nursing especially requires every bit of strength you possess. Long days, sleepless nights, lab sessions. I would often ask myself the question, oh, why did I sign up for this? My colleagues and I complained with every chance we would get. At the time, walking back and forth from Mandeville East Campus to main campus in the sun. That was the life of nursing students back in 2019. The trek was either for chapel, class, or to print documents for assignments or presentations. That was the norm for us nursing students before the interference of COVID-19. Then, on Friday, the 13th of March 2020, the beginning of the end approached us. Everything came to a standstill for a moment. Confusion and frustration swooped in as everyone made a big fuss about what would happen next and what the government would implement. Little did we know that we should have appreciated the things that made us miserable. Everything changed so fast, even quicker than the blinking of an eye. COVID has robbed us of so much. How are we even still stable? It was just like hello and goodbye. COVID has put a lot on our plates that we might never be able to fully consume. There's so much happening. Losing loved ones, studying, special clothing, avoiding COVID, and vaccination. It's a lot to bear, working under extra pressure to which we are not immune. Now we have less time to socialize, and before you know it, we're in the hospitals for a clinical rotation. Yes, we are at the point now when we realize that we have no choice but to push through and go with the flow. There's a duty to be fulfilled by those who signed up for it. Even when the roads become more rocky and we cannot see the way to go, we must be strong for both ourselves and others so that we can all benefit. COVID has taken a toll on everyone, everywhere, and everything. Extra precaution is now being taken in every aspect of providing care. Frequently wearing hot PPEs and reduced visitation are a few changes in the hospital setting. Constantly wearing masks that is disturbing our breathing pattern and depriving us of fresh air. We still do not know all that there is about the novel coronavirus. Too often, there is mention of a new variant, vaccine, and booster that turns our smiles upside down. We are living in the midst of uncertainty, and that can make us nervous. It feels like a circle, just going around and around. We have all seen that this virus has more strengths than weaknesses. It's a massive world war between humanity and the unseen. Spinning around like a gig just to find a cure seems helpless. But what about the future? We had better focus our attention to the Supreme Being. We can rest our uncertainty in the assurance of the Lord, for He says He knows the plans He has for us, to prosper and not to harm. Plans to give us hope and a future are all a part of His word, taken from Jeremiah 29 verse 11, and that should keep us warm. No one knows when we will return to normal, or what we consider normal to be, where we can stop trying to imagine what the other half of a person's face looks like. We just want to be outside, interacting, breathing fresh air, happy and free. Lesson learned, complain less, and appreciate all that we can while it's still in our sight. Thank you.
Wow. That's the perspective of Miss Shana K. Spence, our junior nursing student. So we're going to move into our first session, and our adjunct faculty, Mrs. Alomalai, will do the introduction of our speaker. Mrs. Alomalai, over to you.
Good morning. Thank you very much, Mrs. Wright. Good morning, everyone, and welcome to our symposium. In the 19th century, two nurses, Florence Nightingale and Mary Seacole, made remarkable contributions as they assisted the wounded during the Crimean War. Fast forward to the 21st century, and we find ourselves in the midst of a war. That is the COVID-19 pandemic. The changes resulting from this pandemic has impacted every sphere of life on Earth. and the nursing profession has received more than its fair share. From Kettering Health in Kettering, Ohio, is Mrs. Marie Lee Smith to share with us the state of professional development in nursing, implications for the future. Mrs. Marie Lee Smith stands at the forefront of nursing professionalism as a leader with exceptional outcomes across multiple hospitals while decreasing costs and increasing quality patient care. As Kettering Health System Director of Nursing Education, Practice, and Research, she leads large multi-site endeavors, including simulation research, nurse residence program, and team steps. Dr. Lee Smith holds a Master's of Science degree in nursing from Northern Kentucky University and is currently a PhD nursing research candidate at the University of Cincinnati. She is therefore more than qualified to address us on the topic, State of Professional Development in Nursing with Implications for the Future. Ladies and gentlemen, help me deliver a warm welcome to Mrs. Marie Lee Smith.
Thank you so much. I really appreciate the opportunity to come and speak to the nursing colleagues here at our
Hello, Northern Caribbean University. My name is Marie Leist Smith, and I am from Kettering Health in Dayton, Ohio, United States. I am very pleased and honored to be presenting today my research that I've done with my colleagues for the Association of Nursing Professional Development Specialists. We were commissioned a couple years ago to do an integrative review of our state of research science for nursing professional development specialists, which are also called NPDs. So really the impetus for the review is we met with the board of directors led by Dr. Mary Harper several times to plan the review, to determine the study goals of the research study. And yes, our goal was to describe the current state of research science of nursing professional development practice. However, the main intent of this review was to really raise awareness amongst nursing professional development practitioners about areas for research and evidence-based practice. And lastly, this research study was to really inform the board of directors in setting future research priorities. So the research question that the board of directors and our research team decided upon was, what is the state of nursing professional development research science as reported in the literature, reviewed from 2007 to 2017? To answer this question, we conducted an integrative review using Whitmore and Naffel's methodology. There are several different research methodologies out there, but we really chose Whitmore and Naffel's methodology because this is the broadest type of literature review that allows for simultaneous inclusion of experimental and non-experimental research to more fully understand a phenomenon of concern. The inclusion of experimental and non-experimental in one literature review is of great significance to nursing professional development practitioners and nursing at large because we utilized answers from both types of studies to improve health and the healthcare outcomes for our patients. Most importantly, during this presentation, I will describe the 5 stages of Whitmore and Naffel's literature review process. But because time is of constraint, this will be a broad, high-level review of our methods and findings. However, more details are being published here very shortly in the Journal of Nursing Professional Development. So looking back on history, the Association of Nursing Professional Development, ANPD, has commissioned every 10 years to do a review of the state of the science for nursing professional development. And really to understand where we have come from and where we need to go, we need to understand the history of the literature that was published. So in 1985 to 1995, the very first article published about the state of research science was 124 articles were published, but they were limited to abstracts, only being available to review that were relevant to NPD practice. Over the next 10 years, there were 203 articles published with full text articles, and they performed a rigorous review using rigorous methodology to help narrow down the number of studies. In this review from 1996 to 2006, they were able to narrow it down to 8 articles that impacted nursing practice. And within those articles, the studies of the goal was to replicate the methods to determine changes over the past 10 years in nursing research science. So the goal was to take those 8 articles and to launch where we are today. So in this research review that we did, the integrative review that we did in 2007 to 2017, we used the same research question that we've seen over the past 20 years. We used the very similar definitions, inclusion and exclusion criteria. What is different this year and for this review is that we had a librarian on our team, and librarians make a significant impact to help support the rigor of a study. And then we also use the application of the nursing professional development practice model to leverage and relate our outcomes. So here is the nursing professional development practice model by ANPD. We were privileged to really use this practice model to serve as our guiding framework to partner with the Whitmer and NAFL framework. In the evaluation stage of the literature, we use the framework to guide our inclusion and exclusion of articles based off of roles and responsibilities of the nursing professional development practitioners. During the analysis stage, this means that we used the inputs on the left-hand side, throughputs, the middle section, and outputs to categorize our findings based on the different types of research found in the last 10 years. We'll break these categories down in just a little bit more when we describe our findings as a report of the state of research science. But before we dive into the practice model and our findings, we need to fully understand our research methods for the literature that we used to support our research question. So one of the benefits of having a librarian on this research study is to help search ideal databases as part of this literature review. So our review searched PubMed via the National Library of Medicine's website of pubmed.gov, and CINAHL Plus with full text using the EBSCOhost interface. So because we were conducting an update on a previous review, we were able to limit to a specific span of years. In this case, we chose January 1st, 2007 through December 31st, 2017. There was an exhausted list of exclusion criteria that will be discussed in just a minute, but in an effort to reduce bias and to maximize precision and recall, only 3 of the exclusion criteria were able to be incorporated into the literature search. And so we excluded and limited us to English language only, United States only articles, and articles that focused on nurses in professional settings. So we did not focus on students or academic settings. The literature search was developed by compiling the search strings in the main concepts of the research question. The string for professional development included terms such as continuing education, in-service training, on-the-job training, professional or clinical competence, and so on and so forth. The nurses concept included nurses, midwives, all nurse practitioner specialties, occupational health nursing, public health nursing, and school nursing, just to name a few. The research was the most challenging concept in terms of creating a search string to search by. Only searching for the word research does create problems for precision and recall. If the article in question only ever identifies itself as a random controlled trial, the word research is never utilized. The article will not be retrieved. So to combat this issue, an exhaustive list of terms was compiled and incorporated into the search. The reproducible search string will be provided in the entirety in our manuscript being published. So the previously mentioned exclusion criteria for academic and United States were incorporated into the search by creating search strings and not noting them as part of the search. For example, a list of foreign countries was compiled, and this list was then excluded from the search. During our concurrent session, we did describe what the best practices for an integrative review literature in more detail, and that can be found online, which is great for free review as well. So, not explicitly required by the Whitmore and NAFL guidelines, incorporating a Prisma flowchart is standard for other review types and is incredibly helpful to visualize the integrative review process. The Prisma flowchart organizes the number of results by identification, eligibility and screening, and inclusion. You can see here that we started with 5,146 Synol recordings based off of the search strings that we just identified, and 4,355 PubMed articles. So that left us with a total of 9,501 articles that we identified based off of our search criteria. And then after we searched and deduplicated each of those, we ended up with 8,603 articles to screen. That was nothing but short of a daunting task. So of those records, we ended up excluding, based off of our inclusion and excluded criteria, 7,644 records were excluded. So what that means is for full text articles, for us to assess for eligibility, we had 939 articles that were part of our eligibility criteria. Once we read through all full text of 939 articles, we ended up with our study analyzing 546 articles. The reason why we excluded 393 was because some researchers did not have institutional review board. They were quality improvement and not research focused. We did find some that our search string did not exclude for us, were non-US based, and then also some did not have a design along with them. So as you can see here, we started with over 9,000 articles, and based off of a rigorous review method, ended up with 546 full-text articles to be included in this study. The other piece that we evaluated was our full-text articles over the number of years. So look at this diagram. In 2007, of our over 500 articles, only 23 were published, and then exponentially increased was 73, which is really amazing. And so to set us up next for the next part of our presentation is really to look at the inclusion of articles based off of the scientific rigor of a planned study. So we really want to look at each of the components of a study, of definition of research, IRB approval, literature review, research plan design, and sample design and size, procedures that reflected implementation of the research plan, and research outcomes that were related to the scope. So looking at all of that as we reviewed the 546 full text articles, nursing research has grown exponentially year over year over year, which is phenomenal. So back to our nursing professional development model. The analysis of articles into the alignment of the nursing practice model was really used as a guide to find our research, to analyze our research findings of the 546 articles. In doing so, we sorted and labeled the research articles based on the environments, inputs, throughputs, and outputs of this practice model. Similar to the scope and standards of our ANPD practice manual, we'll start with the discussion about the environment and inputs, followed by throughputs and outputs. So first, all nursing professional development activities occur in the context of interprofessional practice and learning environments. The environment gets us at the where of the NPDS scope of practice. It consists of the structural and social and cultural settings in which healthcare occurs. It is dynamic and influences practice behaviors. The inputs of the nursing professional development practice model describes the when and the who of our scope of practice. Really, the who is the learner and the nursing professional development practitioner and how they interact together and contribute to the professional development processes and achievement of measurable outcomes such as learning change, competence, and growth to improve health and healthcare outcomes. Advanced practice nurses who were involved in the nursing professional development research really were our learners in the practice environments. The learners included advanced practice nurses, registered nurses, licensed practical nurses, certified nursing assistants, and then the various amount of environments that we found in our 546 articles were acute care, long-term care, nursing homes, and community settings such as schools and public health. The learning environments included where the learning took place included classrooms, simulation laboratories, virtual environment, and learning practice settings such as dedicated education units. So the next step was our throughputs, and this is where the heart of the 546 articles lied. The throughputs really delineate the how and what of a nursing professional development practitioner's scope of practice. Throughputs occur in the context of interprofessional practice and learning environments and are based on the inputs, the input of the learner and the nursing professional development practitioner. So how did we get this accomplished? The standards of practices provide structure on the nursing professional development practitioners and how they should perform in their specialty of practice. The roles and responsibilities of the nursing professional development practitioner make up the scope of practice. So the practitioner responsibilities include onboarding and orientation, competency management, education, role development, collaborative partnerships, and research evidence-based practice and quality improvement. We sorted and labeled all 546 of our literature review findings into each of these categories. This was driven by the purpose of our study and the questions that we were aiming to answer through the research. So now we're going to break down each of those throughput sections to really help you understand where are our outcomes related to each of those in our 546 articles. These next few slides are really set up to try to help with the depiction of what was the most, which is on the left-hand side, versus what was the least amount of articles identified. So looking at competency management, many of the studies were addressing deficiencies in staff members' competence. We're trying to get at this with the perception and description studies, and the majority of the competency management studies were based off of self-created questionnaires to address perceptions and attitudes of the learners. A moderate amount were supported by how do we document competency and address those needs for supporting and addressing deficiencies. However, on the right-hand side, there was very little research that addressed competency management and related that to the patient's outcomes. When we look at education, our nursing professional development practitioners design educational activities to address practice gaps for identified targeted audiences, which is the learners. The practitioners use knowledge and skills to enhance the professional development of nurses. There is a great deal of literature regarding program interventions, especially with simulation. Most of the education research measured short-term retention. Minimal education research focused on long-term retention and patient outcomes. So really, when we looked at the body of work that aligned with education, many involved short pre-test, post-test interventions, and then also did not translate those into long-term retention and how does that impact our patient outcomes. The throughput concept of role development supports nurses to increase their role in regards to leadership, really using Benner's novice to expert, teamwork to really enhance the role of the nurse, and really the majority of the research aligned with the Institute of Medicine's recommendation for transition to practice programs to support the novice nurse. Often research compared to the outcomes of novice nurses and expert nurses. There is a gap in the research that examine the competency and the proficient nurses. So those nurses that are really novice and those nurses that aren't experts yet. So there is a gap in the research, and there are very minimal studies that looked at this in-between phase of our proficient nurses. Several studies did support obtaining certification to improve patient outcomes and employee engagement. But minimal research was conducted regarding mentoring, succession planning, leadership development, and role integration. The NPD practitioner supports collaborative partnerships to improve workplace engagement and partners with academic settings. As you see here, there is minimal research on this topic, as denoted by no words on the left side. The research was included in our study was workplace incivility and violence, communication with leadership, and dedicated education units. There is a lot more work that can be done to support research about collaborative partnerships and how that really impacts patient care. NPD practitioners support evidence-based practice and research by supporting the application of evidence-based practice principles in research methodology. Additionally, tool development and validation to support the NPD practitioner is vital. Most of the research in this review assessed attitudes and confidence of nurses using evidence-based practice principles or research methodology after an educational workshop. Little research assessed the outcomes in regards to utilization of the new knowledge. There is a good start on tool development and validation for nursing practitioners, NPD practitioners to measure learning. However, many of the tools were self-created and not assessed for validity or reliability. Orientation and onboarding is a very fluid process of hiring, orienting, socializing, and really integrating the employee to the organization with a focus on retention and growth. Orientation is a facet of the orientation process and is comprised of an individualized program for nursing and other healthcare professionals. There is a gap in literature to assess these. The two articles that were included in our study were about novice nurse orientation and retention. Additionally, research is needed regarding hiring, socializing, onboarding, processing, and enculturation. There is room in our research catalog to add research about orientation and onboarding. This slide is really important to see where our strengths in research priorities are in regard to our throughputs. So if you look at competency management, the majority of the articles were from competency management, followed by education. The areas and gaps where we need to increase our research are regarding orientation and onboarding and collaborative partnerships. For example, orientation and onboarding had only 2 articles of our over 500 articles that we assessed. This is an area of opportunity really to understand the socialization, retention, and enculturation of our nurses in our organization and the role of the nursing professional development specialist to support that. So back to our nursing professional development practice model here to round us out to look at our outputs. So first we talked about our learners and who our learners were. We'd recently just talked about the throughputs, breaking it down into each of the circled categories and what our outcomes were. But then lastly, this output section represents the overall desired outcomes of nursing professional development practice and represent the why of our scope of practice. These outcomes are learning, which helps us lead to change, which leads to role competence and growth. As depicted in the model, competent healthcare professionals are responsible for protecting the public by improving health and healthcare outcomes. The literature revealed that less than 20% of our 546 articles focused on patient care outcomes. Instead, the majority of the authors linked their findings to outcomes such as learner retention of knowledge, changes in behavior, as well as competence and growth. All of these are good and valid outcomes as shown in the NPD practice model. With future studies, we do encourage NPD practitioners to plan their studies with the intent of addressing the highest level of outcomes protection of the public. So looking back at our study, we did want to identify some strengths and gaps related to this integrative review. Some of these gaps are addressed on the next slide, but first let's review our strengths. So strengths of nursing professional development research is that the review indicates that many of our theories or conceptual frameworks are being used to guide research studies. That is something new that we found compared to the articles from 1996 to 2006 and then 1985 to 1995. So really using those conceptual frameworks to drive our research study was a huge bonus and growth in how we are conducting research among the nursing population. In addition, we noticed an exponential growth of our year-over-year growth of research and published research. We noticed an increase in quantitative studies. One of the gaps from the previous two studies was that there was a lot of qualitative research using more rigorous methods with quantitative studies, and also making sure there was a diverse amount of settings was huge for each of these research strengths year over year. So gaps in our research. The literature review revealed gaps similar to findings from our studies about 10 years ago. During the review, we found that quality improvement work was being presented using similar language, methods, and reporting structures as research. In essence, there is still a great deal of confusion in distinguishing between quality improvement and research. Leveraging the expertise of your institutional review board or research committee to determine whether your study meets the definition of research or quality improvement. While we did note that there was increase in quantitative research, the designs were weak. Research methods designs were not well articulated in the research articles, making it difficult to appraise and evaluate the studies. Small sample sizes and the need for power analysis for valid statistical conclusion were amongst part of the gaps. Since there is a disconnect in planning and developing protocol, which helps with thinking through the research process, such as how to mitigate attrition, many of the research studies were labeled as having a descriptive research design. And we suspect that descriptions already exist for a number of phenomena or problems benign and beginning to be described. This goes back to conducting a thorough literature review to ask the right research question to design the right study. Third, valid and reliable instruments. The tendency to create surveys without validating them before use. We did do a call to action with the board of directors to help researchers and nursing researchers use and create and develop valid and reliable tools that could be easily replicated and used throughout our nursing practice. And lastly, protection. Research outcomes related to creating competent healthcare professionals who improve health and healthcare outcomes for patients. Really looking at how does our research impact the protection of the public and translate to outcomes. So just as a review, the nursing professional development practice model really serves as our guiding framework for areas to conduct research. So the future of nursing research, we strongly encourage to engage in interprofessional research teams that really includes librarians, statisticians, etc., while reporting guidelines such as Whitmore and NAFL, like we use today to conduct our integrative review, will help provide that rigor and really help us leverage the strength of each of our research studies. Guidelines provide evidence-based rigor to a study to meet merit and validation of your outcomes. Quality improvement in research should help inform each other. Quality improvement is the implementation of research on one unit to impact that unit. Gaps in the ability to implementing the quality improvement drive research to develop innovative ideas. Research then uses rigorous methods to develop new knowledge that is generalizable to like populations. So the difference between them is quality improvement is limited to one unit in one population area. Research then takes those gaps and those practices to innovate findings that are generalizable to like populations, but they need each other. You can't do quality improvement without research, and you can't do research without quality improvement. The future of NPD research needs more education research workshops for all nurses to support innovation and generation of new knowledge. We are also recommending that there are more frequent integrative reviews, since there was a tripling in the amount of research over the past 10 years. So more integrative reviews need to occur, recommended every 3 to 5 years, so that way there can be a more robust drill down to each component of the nursing professional development model. The researchers in this study of over 500 articles did a great job assessing nursing perceptions, baseline knowledge, attitudes, and confidence according to the NPD practice model outcome measures. But outcomes need to include the patient. Patients were missing in the most needed way for each of these studies. As nursing professional development practitioners, we are held accountable to relate our work to the strategic priorities of the organization. Future research to include patient outcomes will help demonstrate our value to the organization. So for example, the future of nursing professional development research and any nursing research is right on your unit. This here is one of the nurses that I worked with. She started her project with a quality improvement project, really looking at delirium and how delirium using the CAM assessment tool could impact her patients. Now again, those were quality improvement projects, one location, using an evidence-based tool to implement. However, what Kristen found doing that quality improvement was that they were missing vital pieces to assess what was the patient's state and the family interaction with the patient who was delirious to really improve the health and patient outcomes. So then Kristen partnered with our research team and really looked at ways to integrate the family into that delirium interventions, and did a research study based off that, and did it over multiple sites, multiple different places, and was able to generalize her findings because of the way she set up her study. She had a valid, reliable tools for family integration that she married with the CAM delirium ICU. And then she also had a good sample size of patients and family members who participated to really help assure that she had statistical significance. So Kristen has recently implemented these assessment tools, is partnering with the American Association of Critical Care Nurses to implement these additional measures to help support patient and family interaction to improve the patient's outcomes on her units. And it's all because it started with quality improvement, but then quickly noticed where the gap in research is. So her new protocol for CAM and delirium assessment really aligns with the nursing practice model in the area of competency management, because she needed to help make sure that the nurses on the unit that she works with were competent in delirium management, and how do they engage the family members to help support and decrease delirium. She also did a rigorous randomized control trial that focused on the outcomes of the family members and the outcomes of the patients. Both groups had a valid and validated pre and post knowledge test, and then also translated that into patient outcomes based off of their medication usage, length of stay, and the consistency of the use of the tools to decrease delirium by the family members. So these findings are also generalizable to other ICUs and other patients in like situation. Now all nurses in the ICU throughout this organization's 5 hospitals use this approach to delirium, which is pretty amazing. So, tools and resources for success. Definitely recommend getting on the ANPD Spirit of Inquiry website. This website is designed to take the findings from this study and to state this is where research needs to go. How can we create the spirit of inquiry with the partnership of quality improvement in research, as I just described? Also partner with local professional nursing organizations. These national organizations and local organizations help you identify, make connections. As I met my partner, Emily King, the statistician, through a local professional nursing organization, and she was really able to drive the success of including all of these articles in this study. Lipsy tables. Search and Google search Lipsy tables. They are amazing. They help you determine sample size to make sure that you have statistical significance in your study. Another great way for identifying research and to really help break down all the key pieces that you need in your research is the Judith Garrard matrix method. And then textbooks for conducting research. Often we are aligned for making sure that we have good search engines, but really relying on our textbooks for conducting research and using that consistent methodology is really important. And lastly, network. Network at your conference today. Stay in touch with your peers and colleagues and really get out and touch base with local nursing professional organizations. They really drive that spirit of inquiry to help us lead nursing professional development research. So here are just some of our resources that we used for these. And I cannot thank you all enough for letting me present our work that we did back in 2019 at the Association of Nursing Professional Development Conference. We were commissioned to be one of the keynote speakers to really share and celebrate the past 10 years of nursing research at this Aspire to Lead conference. And we are looking forward to having our work published here very soon, and also really looking forward to how the board of ANPD is using these outcomes to drive the spirit of inquiry for research. And so I thank you all so much. Please feel free to reach out to me if you have any other concerns, questions, and I look forward to the next generation of researchers. Thank you.
Thank you, Mrs. Lee Smith. At this time, we'll entertain questions. Any questions for Mrs. Lee Smith? Thank you so much for that very well-informed presentation on research, nursing professional development, and also identifying the gaps in your research. Indeed, the patient is the most important component in the nursing meta paradigm, and we need to include patient outcomes and also outlining some of the resources that we can use as we embark on our research. Any questions? No questions. Okay. All right. So
there's a question.
Again. Sorry, there is a question.
Yes. Good afternoon.
Okay. Good
afternoon.
Yes. Go ahead, please.
Yes. Thank you for the excellent presentation. My question is the nursing development, professional development. Do you have an association? Do you have a group where students from like this very institution, the Northern Caribbean Institution, could always participate like we have other professional bodies? I'm talking of the nursing development professional development? Do you have it as a group where students from this institution will want to be a part of, or you normally have different conferences, or you have different webinar, or whatsoever is being done as a professional group that students can be part of to enhance their learning and to gain points as in refresher of courses for them in the process of their profession?
Absolutely. That is a great question. So ANPD, I will put their website in the chat here for everybody. And yes, there is a huge, since we've done this research, there is so much more research and educational presentations focused on novice nurses and students, and
Mrs. Smith, you're muted. Could you just unmute?
Can you hear me now?
Yes.
Great. Thank you so much. So the Association of Nursing Professional Development Specialists is available for students to join as well. They have been using much of our research to support orientation and onboarding of novice nurses. There is a lot of presentations out there now on ANPD's website and for membership. And if you're a member of that organization that talks about emotional well-being of our nurses, to support during orientation, spiritual well-being as well, but then also that competency management and how we need to be innovative in nursing practice to support that. So it is a great resource for both students that are transitioning to professional licensed RNs, and also for their peers and colleagues at universities and at our hospitals to help support that integration and education of our nurses. So I'll put that link in the chat here for everybody.
Another question, please,
yes.
As a follow-up. As a professional body, therefore, do you facilitate employment for your members? Like there are students in this institution, they want to do some probably internship or some work within. Do that group facilitate? Maybe you say come to an hospital in your area, do you make that collaborative connection for your members? Do you?
So at this time, there are several associations that do that. However, ANPD does not make that career connection. There are other organizations, though, however, like the Association of Critical Care Nurses, helps make connections between organizations and nurses, and even nursing students who want careers in critical care nursing. Same thing with the Association of Medical Surgical Nurses. They have a careers page that helps make connections between students and those bodies, but the Association of Nursing Professional Development currently does not have that platform. But Kettering Health,
thank you.
Look at us. We are a pretty amazing organization. I've been here at Kettering Health for going on 3 years now, and have really appreciated the partnership with our chaplains, our spiritual care services, and our mental health departments. Listening in on this morning's presentations, it really was profound and eye-opening to me that how all of nursing is impacted worldwide. Many of the experiences that you all were sharing is exactly what we're experiencing in our organization right now. However, we have set up intentional resources at every single nursing class that our nurses have. We have a chaplain there to pray, to provide spiritual guidance, and then we also have a mental health technician to come and help debrief to support the mental health well-being of our nurses. So highly encourage, if you're looking for career and career opportunities, Kettering Health has been an amazing support. And one day we want you all to come work with us.
Great, thank you. Thank you very much, Mrs. Lee Smith.
Thank you. Thank you.
Good. Alrighty, so we will move on now to our Next presenter. Adjustment. Adjustment is a process that sometimes calls for patience and flexibility. And COVID-19 has caused us to exercise both to the nth degree. The pandemic caused disruptions in clinical rotation of nursing students. Adjustments had to be made. The training of nursing students had to continue. After all, nursing and nursing education is a continuous process. The use of simulation, though not new, has ballooned to assist with exposing nursing students to clinical scenarios to aid in the development of their skill and competency. In our presence today, we have an expert in the use of simulation. She is Dr. Caroline Mclean. Dr. Mclean is an assistant professor here at Northern Caribbean University in the College of Applied Sciences, Allied Health and Nursing, where she is also a consultant in healthcare simulation and faculty development. Currently, she is one of the 81 certified advanced healthcare simulation educator in the world. She's also a Team Steps TM Master Trainer, Stop the Bleed Ambassador, and a Stop the Bleed Instructor. Dr. Mclean has worked in simulation healthcare since 2007 in several capacities. Owing to her various simulation and clinical experiences, she developed, implemented, and assessed multiple simulation programs, curriculum, and learning modalities for interprofessional education groups, higher education, practicing clinicians, military, and international entities. As a leader in simulation education and continuing professional development, Dr. Mclean serves on committees with the Society for Simulation in Healthcare with experience in national accreditation for healthcare simulation programs. Her research interests focus on simulation-based education and IPE. Ladies and gentlemen, help me welcome to the podium, Dr. Nikki Mclean. Over to you, Dr. Mclean. You need to unmute
Thank you so much. Can you hear me?
I hear you now, yes.
Okay, awesome. Awesome, thank you. And I appreciate being at the virtual podium today. Just to share just a little snippet of simulation, obviously. I think that was clear after Mrs. Lai did the introduction. So thank you very much for the introduction, Mrs. Lai. So I just want to share in just a short few minutes, so to speak, just a very minute component of what NCU, the nursing program to be more specific, but the university at large attempted to do for last semester when it came to simulation. So we've had people talk about COVID pandemic. It's a commonality that we share. And so everybody understands that, and everybody can appreciate that it has caused certain challenges in how we go about providing education, because we are about education. And so part of that, as it relates to the nursing program, was the burden of figuring out how to get lab sessions for the learners, and more specifically for the junior and for the senior learners in the nursing program. So even before COVID, there was a need for simulation and the use of simulation to substitute or to take the place of some of the traditional training. And that was the plan, and we're moving along that line. COVID just catapulted us well into the future of where we were. So based on the fact that there's that need for integration and the utilization as a learning methodology, we had to figure out what we were going to do at that moment in time time for the learners in order for them to get the labs done, in order for them to be ready for the clinical setting. So we were, needless to say, under the gun in how we went about doing that. So the best solution with the time that we had, the time constraints, the financial constraints, was to ensure that we had where the learners were able to get the hands-on experience that they needed for the training. Just a minute. All right. So then what we ended up doing was we looked at virtual component, the virtual modality of having simulation training for learners. So the purpose of this pilot, because it wasn't a full research, that's the plan down the road, but this was just a pilot at the moment. As we were flying, we were reading out of the manual in a sense. And I think a lot of people can relate globally, because that's some of the stories that we've had globally with the challenges that people have faced. So the purpose of what we were doing was to see how we could integrate a virtual sim experience for the learners for those weeks that they were with us. It was a number of weeks. They were already 3 weeks into their semester. So we were coming right kind of about a quarter of a ways to finish the other 3 quarters. So I'm just going to take the next few minutes to share the feedback that we collected from the post-activity survey with the learners and the experience of the virtual simulation. And this is specifically looking at the juniors and the seniors when they were going through the lab. So as a foundation, or to set the foundation, no one can argue that simulation is now a widespread pedagogy in healthcare education. Simulation has always been around, and even as far back as the 16th century. It has been in other industries. It's just now come into healthcare in the last 2 decades. And so with that introduction into healthcare, there was a lot of changes that we had to do, and the learning curve was a challenge because we weren't used to the approach that was taken, and so we had to get used to that approach and that mindset and that thought process. But once they got on board, it really got integrated into what it is that we're doing. So with simulation as an educational strategy, the whole focus is to improve the KSAs for learners. So it's the knowledge, the skills, the attitude. It's also to support the already established curriculum that exists in higher education, and in this example, or in this situation, in the nursing program here at NCU. So it's agreed, it's beneficial because it helps learners to assimilate and to synthesize what it is that they're getting from theory, what it is that they might be getting from skills lab, and incorporating that to tie it in, and almost like a roadmap or a bridge to connect to clinicals. And so it is even more now very accepted and very well received educational strategy worldwide. So it's really good for healthcare that this has happened, because it's a good that has come out of something so very traumatic like the COVID pandemic. But at the end of the day, we need to do more than just that. So we have gone ahead into the future, but we've actually outpaced ourselves where the technology is not keeping up with what it is that we really need to do. So people have looked at immediate solutions. And it's not so much Band-Aid, but that would be the best example I could think of. But for right now, how do we stop the bleed then? And then once we figure out where we are and what we're doing, how do we then set up things that are standardized in order to move forward? So that was kind of just a basic introduction. So there is a need for simulation. A lot more people are doing simulation. We need to be standardized, but there's also that component of technology. And you'll see a little bit more with the challenges that we had. So as far as like a little background, the virtual lab sessions that years because of that in-person restriction. So they couldn't go into the actual lab to do the hands-on. So there is obviously a big disadvantage with the fact that they can't do the whole tactile, the skills, the return demonstration in the way that they would normally be used to in tradition. And there's just some things that in healthcare, because it's such a technical career and skill set, you have to have that hands-on and you have to return that demonstration. But as I said, we were doing with what we had and what we could do at the time. And that was the pattern even from the very beginning of COVID with students worldwide with different programs. So we use a cloud-based software program that we acquired. We were under the gun, so we got a pretty formidable software program to utilize for the students to interact, for them to be able to access skills, for them to be able to access scenarios, and to integrate that more in an electronic health record opportunity. So there was quite a bit of focus on documentation, but we had to tie in that interactive virtual and video interaction as well to make it close to being realistic as we could, but there were still the obvious challenges. So that was an access point for the students to be there and to actually engage and maybe synthesize the theory of what they needed to do. So based on all of that, the significance of it all is because of the pandemic, why we had to do the way that we chose, which was the virtual. As a side note, now that the pandemic is, I can't say going away, but the pandemic is a little bit more under control. We are looking to do more of that back to in-person with the simulation activity and doing some of that traditional simulation in the simulation lab. And I'll talk a little bit about that later on. So it's that replacement that needs to happen because of the limited clinical space. So healthcare has changed. Healthcare is not going back to where it was. There was already limited clinical space in hospitals, in healthcare facilities for students. That has maximized and it has gotten more pronounced. And so education institution, stakeholders, hospitals, government, you name it, are having to look at different ways, boards of nursing, of how to provide as much opportunity for learners to get their practice before they go into the clinical setting and take care of patients, because it really comes down to patient safety. So that's how significant this is. We're not going to necessarily build new hospitals and facilities to accommodate. So there is that limitation. And so working with that and being creative is something that is very important. So what I'm going to do, I'm going to just play a couple, 2 short clips of just a snapshot of a patient encounter that we did virtually and tie in some of the interactions with the student and what took place. Okay. And so so hopefully the videos will work here. It's storming where I am, so.
All right, I know you've been kind of exhausted.
Just let me know if you can hear that.
Seeing that this is your first pregnancy, we need as much information as possible, all right? Okay. So I'm gonna be doing your surgical history. I know that you mentioned that you had a pregnancy before, but you had a miscarriage and they scraped you out. Can you tell me what date did you have that procedure? Do you remember when?
I try to remember because I did around
Let me just pause just for a second and let me go and see if I can just show the live video just by itself. So just give me 1 second and let's try it this way. See if it'll show live, and let me move this over. Let's do that.
Thank you. Okay. All right, I know you've been kind of exhausted with questions, but seeing that this is your first pregnancy, we need as much information as possible, all right? Okay. So I'm gonna be doing your surgical history. I know that you mentioned that you had a pregnancy before, but you had a miscarriage and they scraped you out. Can you tell me what date did you have that procedure? Do you remember when?
I'm trying to remember because I did around I know I think I did March. I think I did February. It was after my birthday. So it was in February. And here, like I said, start bleeding, carry me going, and then they say the baby dead. And then say I did 12 weeks along I was. So I think around February, I'd have to look and ask, I did around February 25th. I did after Valentine's Day.
All right, so February 25th, was it this year or last year?
Last year.
So February 25th, 2020. All right, just a question. After the procedure happened, what can you tell me about your cycle? Did you get back your cycle? Was it irregular? Did you have
It take a little bit, and then it just like me never know when to expect it, and then it did get back regular.
All right, so you had a delay with your cycle. You had a delay with your cycle.
I did.
And after the surgery, did you have any pain or any discomfort? Can you tell me how long you recovered from that surgery?
It did feel like a heaviness and then cramping. Me did have. And then Mama never wanted me to do nothing but me to try like get up and help her, but probably about 3 or 4 days. She just in a bed and rest, and then we start move around a little bit, and then we just start get better after that. And she give me some bush tea and that helped me. You can't go wrong with them something there now. So I always can't go back to the bush. That's why me live in a bush, kind of right next door, so I can do tea. So that helped me, and it helped with the pain because I never take no medication. They write me prescription, and I never take no prescription for it because I say I don't want no whole heap of drugs in my body. But me did smoke some weed, and that did help.
Okay, just for advice, next time you should take the medication because it's good to have your herbal ingredients, but medication do help. And I have advised that weed is not a source to help with pain, all right?
Oh God, making a chew, no herb.
Well, it's true, it's growing, and there's still some researches on weed. However, it's not right now a definite ingredient or a definite thing that you can use for pain.
Let me tell you, I will try, but I don't inhale, but I will try and consider the baby. So
yes, especially now that you're pregnant and this will be your second pregnancy. It's important that you delay or stop smoking for the health of your child. All right?
Me will try. Seriously, me will try for the baby because I still at home with the down most of one day. Me will try. All right?
Yes. Just a question. You mentioned earlier that you're...
Thank you for identifying with the patient being tired. And yes, the first interview is usually the longest. And here's one of the things that the patient kept on saying. The nurse asked me that already. And so on and so forth. So that's another thing as far as awareness with the patients. And then you guys did a good job reiterating to say that yes, but you have to verify. So just always clarify with them to make sure that they understand that it's necessary for you guys to maybe ask the same questions twice. But hopefully you've gathered enough information so that you can start building your patient case. Because here's what's going to happen. Yeah, and that's a good point. So start before. So you see all of these things that you guys are talking about, then that's something that you need to incorporate in your plan for patient education. All right. So very good points, critical points that we would be looking for. So what I'm going to do, and you guys did such a good job, I'm still going to send out some helping points for you. I'm actually going to put it into the Google Classroom so that if there's any areas of focus that you may have missed or may not have gone into details, it will be there for you to reference. Okay, so then I'll play another clip that shows just more of the student interaction with what we're doing. And then I'll just add some caveats to that. So let me go ahead and play this one.
So basically the information that we just got a while ago, we're supposed to use it and create a care plan?
Yes. And then you're gonna create your patient scenario. based on that information. So that's more than enough information for somebody to play the role of Miss Brooks. And however you want to incorporate Mr. Brooks. If you don't want to incorporate Mr. Brooks, you can incorporate the mom. She talked about her neighbors. She talked about the sister.
Good afternoon. I am student nurse Color. May I have your name and your date of birth, please? So my name is Casey Hales, and my date of birth is September 25th, 1996. Okay, Miss Hales, how are you feeling this afternoon? Are you feeling any pain? I'm feeling okay, nurse. I just can't wait to give birth. I'm tired of these backaches and these irregular contractions. Okay, just try to hang in there. You're doing well so far. Your delivery time is right around the corner. Today, I would like to perform an abdominal examination, which will help determine the fundal height measurement. Is that okay with you? Yes, nurse, that's okay. I have provided privacy and I have already washed my hands. This procedure will involve me looking at your tummy, pressing your tummy to check the position of the fetus, measuring the fundal height, which is used to assess fetal growth, and listening to the fetus's heartbeat. I will also be pressing quite deeply but gently on your abdomen. I will attempt to make the examination as painful as possible. If, however, you feel very uncomfortable at any point in time, please do not hesitate to let me know. Would you like to empty your bladder before we begin? Okay, thank you. Okay. Now, to commence the examination, Ms. Hales, I will first remove the top sheet from your abdomen. I will then be inspecting the abdomen for striae gravidarum, linea nigra, and O Caesarean or other surgical scars. In palpation, there are 6 steps I would like to cover. The first one is used to determine the fundal height. In performing this step, I am going to palpate the top of the uterus, which is called the fundus, using my inner aspect of my right index finger, gently pressing downwards and inwards for the very first point of resistance. This will coincide with the uterine fundus. I will then use my measuring tape and place the tip of the tape at the fundus to the top of the symphysis pubis. I will then look at the measurement I have obtained, which should be in centimeters. This measurement should correlate within 2 centimeters to the period of gestation for the patient. The next step involves determining the number of fetus and the lie. To do this, I will palpate your abdomen laterally by gently fixing one hand on one side of the abdomen and pressing in with the other hand. I will then alternate my hands to determine the curve of the fetal back, whether it lies on the left or the right. At this point, I should be able to know whether or not it is a singleton fetus and whether or not the lie is longitudinal. The first step involves feeling the presenting part. This step can be very uncomfortable because it involves very deep palpation. If it becomes unbearable, please let me know. Sure, I will, nurse. Okay, Ms. Hales, I will be placing my thumb and index finger of my right hand just above the symphysis pubis and gently but deeply pressing in for a palatable point of resistance, which should coincide with the fetal head. My aim is to determine whether the majority of the head lies in the abdomen or in the pelvis. Most of the head lies in the abdomen. It is about 3/5 engaged, and if very little of the head can be felt, then it could be about 4/5 or more engaged. My last step is to listen to the fetal heart
Having determined the side the fetal back lies on, I would listen between the fetus's scapula for the fetal heart rate to ensure it is regular. I will use a pinard to place over the fetus's scapula to listen while pressing in firmly but very gently. Ms. Hales, the findings of this physical examination show that on inspection, your abdomen is gravid, linea nigra, and striae gravidarum visible. On palpation, your abdomen was soft and non-tender. The fundal height is 33 centimeters, which coincides with the period of gestation. It is a singleton fetus in a longitudinal line, cephalic presentation, 3/5 palpable, with the fetal heart being heard regular. Thank you for allowing me to conduct this physical examination, Ms. Hales. I hope to see you soon.
Thank you, nurse. I hope to see you during the next visit.
Okay, great. All right, so let me put some context because I have where I gave some comment at the end because the entire class commented about how creative that was that the students had done. But let me give you a little context now that I show that, and then I'll wrap it up with the survey, the post results or post activity survey that we had. So to give you a little context for what all of this was, with the short time frame that I said that we had, so the students were already 3 weeks into their training. Faculty was already engaged with their theory content. Students were all over the world. So they were all over the island in Jamaica. They were all over, well, the island is Jamaica. So they were all over Jamaica. They were in the Caribbean and wherever else they may have been at that time, some overseas in the United States. And we were having lab time because we were online. So there is a challenge there already. So you heard me talk about the cloud-based software that we utilized. Well, with what the expectations are that faculty is going to do. There's that fiction contract where everybody's assumed to have an opinion that matters and that we're going to respect each other when we interact. And then whatever we do in the simulation or in the virtual arena stays in the virtual arena, and it should not be discussed outside of that environment where it's not productive. So if it has nothing to do with what you're doing outside of class, then it's irrelevant. So it has to be a therapeutic discussion, so to speak. So there was orientation that was provided, and these were, it was based on 54 responses. Did you find the program beneficial? So 27.8% said no, and 72.2% said yes. And there are underlying factors as to why this was less clear. 42.6% said it was neutral, 29.6% said it was clear, and 14.8% said it was very clear. Was there a good balance between lecture and practical learning? So this is where, you know, the given challenge of COVID was. Of course, they would rather be in person, but with the published area in simulation. So considering the limitations of a virtual learning environment, at least the one that we had, and we had to deal with, which was pretty much going on the computer and being on Zoom and then getting into the documentation, like I said, how realistic was it? And of course, it leaned mostly to the left because it can be a bit tedious to navigate. and I say amen to that, that the simulation program begins simultaneously with the theory aspect of the courses offered for this specific semester. And that's exactly right, because when they started out, that would have been the plan. But with the new restrictions that happened, then there was that no in person. So then everything had to be virtual. So that's a well taken point as well. I think being more organized would make this experience better for others. It slowly started to feel worthwhile in the end. So it does feel like chaos, sometimes sort of organized chaos, but over time, but with the right technology, it should not be that way every single time. So in their own words, as far as the sessions that they found most relevant, some found watching the practical video or watching a practical video that is more to the Jamaican hospital style is what students ask for a lot, because we did incorporate videos. But a lot of the videos that exist that you want to teach about best practice and standards of care are in the United States or in England. So that begs the point, what do we need to do here in Jamaica to make that an availability for our students that is more culturally appropriate, but still meets those standards? So those are some of the opportunities, I think, for the future. Then for the parent neonate, they found that it was practical. They found the orientation being, beneficial, adult nursing too. And they just thought that this experience, it spread across the continuum depending on the scenarios that we were doing. The history taking of the patients, and then the sessions where the students were able to take on roles. And we did that a lot in some of the activities. So final in their own words, additional comments. So this comment I thought really summed it up from the students' perspective. In regard to hands-on training with more resources and sponsorship from both local and international benefactor. Our simulation program has the potential to be great. Under the circumstances we were all subjected to in regard to pandemic, I believe we did our best with what was given to us and made the most of it. I look forward to future improvements. That sums it up, because that is what I would say in the scheme of things. There's untapped potential, period. And I have to say there's untapped potential in the university. And it's not just nursing, but we have to start somewhere. So right now, nursing is that focus. And then we have interprofessional training, because it's not just nurses that work in the hospital. So we really have to look at our curricula, our nursing curricula, to identify where we can best suit simulation. We have done that. So that's already done. So that's a checkbox. We incorporate current best practice into simulation in nursing education. That is in the process, because until you roll that out, you only have the curricula itself, and that's being integrated or has been integrated in the simulation portion of the curriculum that we want to roll out to our students. Providing formalized faculty development in simulation education. So when faculty gets free time, and somebody can let me know what that looks like, the plan is to have their full attention. But until then, we're working on launching the faculty development for simulation. The modules are completed. There are faculty that are interested. So it's a matter of aligning the schedules now. And then tracking the effectiveness of simulation across the learning continuum. And I'll take it one step further into the clinical setting. So that's like the ideal, and that's the sweet spot. And that's where we want to go. However, at this moment in time, as a final comment, we do agree that there's a growing need for simulation, but also for support, both from institution or the institutional support, the government support, and then also the healthcare support. The support that we need is critical in order for us to have a unified, standardized approach for simulation implementation in nursing programs, not just at NCU, but throughout Jamaica, and then throughout healthcare, because there are practitioners that can benefit from just-in-time training where you take simulation into the hospital. So nursing schools that are seeking to develop their simulation program really need to look at the needs of the learners based on the curriculum and how that can be integrated. So what we're doing for next steps here at NCU is to roll out formalized simulation training with the sophomores. That we're going to be doing the next 4 weeks of simulation with the sophomores. So sophomores, if you didn't know that, you just found out. But it has been planned with faculty. We do have the scenarios based on the curriculum, and this then bridges the gap where then they go into the clinical setting. And they're having to, they can clarify, they can get practice, they can do remediation, depending on what the needs are for better patient outcomes. So that's where we are. We're working with what we have and seeing what works, but the resources are important in order for us to leverage the tools in a way that is so effective that it's reflected in our healthcare. Because we're patients, or we will become patients at some point in time. And we want to know that the kind of care that we're getting is from competent, confident, and efficient healthcare providers. And one of the ways to really do that, and it's been proven, is through simulation and through the integration of that in a standardized way that supports healthcare across the continuum. So thank you. I appreciate the time. I don't know if there's time for questions or not, but I am done with the presentation. So thank you very much for your time and for listening and for watching the videos. Hope they weren't too painful.
Thank you so much, Dr. Mclean, for that presentation. Very engaging, highlighting the use of a simulation in preparing our nurses for the real world. Any questions? We're really running behind, so we could perhaps just take one question. Any question for Dr. Mclean?
Yes, good morning still. Thank you so very much, Dr. Mclean. Charlene Sharp, I just sat amazed just listening, and I could listen forever to what it is that you would have shared. I'm really very pleased to see that this is the direction in which we're going. Excellent presentation, having worked in simulation myself in a previous life. But let me ask you a question. Well, given my experience in simulation, I was working at a university. I was a grad student, peered to the pharmacy department, studying what it is that they were doing. And we had started our own simulation lab in the pharmacy department, etc. Weren't getting very far, pouring a lot of money into the process, students learning. And it was not until we partnered with Fetus and Rite Aid and the hospital, and they started telling us the areas that they would prefer for the students to receive their simulation training before we started getting somewhere. So you are hitting the nails right on the head. Question is, to what extent are you thinking that if we prioritize more, I heard the student saying about the Jamaican hospital setting, if we prioritize more or collaborated with our, well, interprofessional collaboration, as you mentioned, do you think we'd get quicker buy-in within the Jamaican system for simulation, and therefore get the sort of support that you will need monetary-wise and otherwise? Because they would know what areas they would prefer to see us using.
Right. So that's a brilliant question, because that's the $1 trillion question, or gazillion, whatever it is, or infinity. That is the sweet spot question, Dr. Sharp, and I appreciate you asking it. And the short version of the answer is yes, that's where we want to go. This is collaborative. This is not just about, one university or one hospital or one location. It is about interprofessional practice. And the one thing that I don't want to get chairing that session.
Good morning, everyone. I want to welcome those who might have just joined this session 2. We do have some presenters for this session, and we hope that you will stay with us. Please place your questions in the chat as you have been doing. And so our first topic is nurturing undervalued treasure, directing the trajectory of holistic self-care. And our speaker, our presenter, is Jonelle Miller, a registered nurse for the past 25 years. She is an assistant professor in the Department of Nursing, Northern Caribbean University. She earned her Bachelor's of Science degree in nursing from the then West Indies College, now Northern Caribbean University. She earned a Master of Science degree in nursing with an emphasis in nursing education and adult and aging family from Loma Linda University. As a nurse educator, she is deeply concerned about sound curriculum development, transmitting caring to her students, and nurturing critical thinking skills through a wide variety of methods and techniques. She is passionate about holistic health care, healthy living, improving nurses' health, active and cooperative learning, and sharing God's plan to make man whole. She has made several presentations in a variety of settings, locally and abroad, to spread her passion and to help others experience optimal level wellness. Seeing each of her students achieve their fullest potential, inspiring other faculty to employ active learning strategies, and effectively meeting the needs of clients brings her great satisfaction. Happily married to Roger Miller, they have 2 children, John and Roger Jonathan R.J. The family facilitates the Destiny of Hope seminar, which is geared toward helping each participant find meaning, wholeness, and connection to their unchangeable worth. Some of her hobbies include gardening, cooking, meeting people, and writing poetry. She highly values family time and spending time in God's Word, which gives her the drive and courage she needs for each day. At this time, I would like you to welcome my colleague, Mrs. Miller, as she presents Nurturing Undervalued Treasure, Directing the Trajectory of Holistic Self-Care. Let's welcome her.
Thank you so much, Ms. Meikle, for your kind words of introduction. And thank you for the welcome that I'm receiving also in the chat. I appreciate that. Let me know if you're hearing me well. Is it clear?
Yes, Miss. Yes, you're coming across loud and clear, Mrs. Miller. Go ahead.
Wonderful. And you're seeing my slide. So
yes,
as we're talking about nurturing undervalued treasure, directing the trajectory of holistic self-care. As we consider the challenges, the global challenges at this time, from novel and emerging and re-emerging diseases, there's a stark reality that persists and challenges that continually test the mettle of our governments, our health systems, and even our personal resilience. Now, the International Council for Nurses has reviewed the global response to the challenges that we face, and they agree that there has been unprecedented damage done. They agree that there has been unprecedented damage on the health systems, on the nursing workforce, and even on individual nurses. And the pressure seems unrelenting, even the issue of even increased workloads and high infection risks and more demands that are made on nurses to cope, to be resilient, in addition to what some perceive to be moral injury. And with all of this, with the high nurse turnover and nurses experiencing a higher incidence of infection, illness, and mortality. The ICN 2022, they have declared this. They have made a plan to sustain and retain in 2022 and beyond. Now, it's time for us to take stock of our own resources and choose to sustain, boost, and retain in 2022 and beyond. Let's look a little closer at this treasure that we have, that we might not have valued as we should. So the purpose of this presentation is to sensitize us to God-given, possibly undervalued personal treasure that, if nurtured, would offer significant benefits in this time and beyond. Additionally, evidence-based principles of healthful living will be discussed, which, if adopted, could enhance the efficacy of the treasure and direct the trajectory toward optimal level wellness in this unprecedented time. So we have been wired with treasure that's invaluable and can protect and improve the quality of our lives. And this review will just be exploring just a bit of what this treasure is and the value of it and how we can enhance it. We are talking about this afternoon, not the frontal lobe. Frontal lobe keeps coming to my mind. The immune system. And we can describe it as a collection of cells, chemicals, and processes that protect the host from invading organisms. As we think of the immune system, we think of two major lines of defense. They work together, they cooperate with each other. We're talking about the innate and the adaptive immune system. It's interesting to note that our immune system uses up to 20% of our body's energy each day. And so it's a very important part of our system. When we talk about the innate immune system, we're talking about that first line of defense. And if the innate immune system is intact and the body is healthy, then we might not need right away the adaptive immune system. But if something harmful passes through the innate immune system, then the adaptive immune system would compensate and continue that fight. We probably can think about it like a soldier and a police force. The adaptive immune system, the hallmark of the adaptive immune system is that it has good memory. And so it can mount a response to an invading organism quickly the next time around. It also is very good at determining self from non-self. So it generally does not attack self. And those are good principles for us to consider. It also stimulates pathways to eliminate pathogens or pathogen-infected cells and cause for the development of memory, as we mentioned before. Let's look briefly and quickly at some of the cells that participate in the innate immunity. So I mentioned cells, but there are also processes. So we can think of our skin, our mucous membranes. We can think of our body temperature, low pH in some areas, chemical mediators, and phagocytic and other inflammatory cells. We can see we have the macrophages and neutrophils, eosinophils, basophils, mast cells, lymphocytes, monocytes, natural killer cells. And just to add, wherever there is injury, the immune system will respond, either inflammatory response or going on with the immune response. Of all these cells, some of these cells also participate in mediating in the adaptive immune system. Let's look a little closer at those. So in the adaptive immunity, we're talking about mainly two cell lines. We're thinking about T cells and B cells. T cells really are fascinating, and they're finding out so much more about the T cells and how cross-reactive they are. So T cells actually are more cross-reactive and can deal with a variety of peptides and antigen, much more than was previously thought. When a T cell has to respond to what we call an antigen-producing an antigen presenting cell. For example, macrophages, or we have dendritic cells, or your B cells, fibroblasts, and even some epithelial cells, especially in the gut. These present a little piece of the antigen to the T cells. And these can be presented on what we call an MHC1 or an MHC2 molecule. MHC1 molecules are generally on nucleated cells, all nucleated cells. If a nucleated cell is infected with a virus or with some tumor cancer, it will process a bit of that and send out just a bit of the peptide on its antigen, it will produce and it will reproduce. Pardon me. The antigen, the cells will show a bit of the peptide of what's going on inside on its MHC1 molecule. Once this is produced, once it is shown, and then the T cell receptor binds to that peptide, then the T cell becomes cytotoxic T cells and makes more cells that will come to destroy and lead to apoptosis of those infected cells. Additionally, your T cells can proliferate to become CD4 cells. These CD4 cells will now call forth for B cells and then other CD4 helper cells, like the helper 1 cell, helper 2 cells, and there are many other helper cells. They're even finding about T follicular, so gamma delta T cells. There are many more T cells that they're finding out about. There are also regulatory T cells, and these come to cool down the immune response after everything is cleared, after the dust settles. And then there's also the B cells that don't necessarily require an antigen-presenting cell. If they find an antigen, they can also produce more B cells and plasma cells, which will produce antibodies. The antibodies do not destroy the offending agents, but at least they flag them and call in the complement cascade and opsonins and destroy these antigen-antibody complexes. This, of course, is quite simplistic, and there's so much more to this, but because of time, we're going to be moving on. But when we think about how fearfully and wonderfully we have been made, it's truly fascinating. I just want to also mention the human lymphatic system as we look at it. And what's most fascinating, yes, we are aware of the adenoids and the tonsils and the spleen, but of interest to me is the Peyer's patches, which actually are a type of what we call gut-associated lymphoid tissue. And so the gut-associated lymphoid tissues are found all over the gut. And they actually sample what's going on in the lumen of the intestines. And if any abnormal antigen, any antigen that's found that is not commensal, that's not to be in that space, then an adaptive immune response is actually triggered. So we have Peyer's patches in the small intestines. We have what we call cecal patches. We have colonic patches. We have isolated lymphoid follicles, and these are present throughout the whole intestine. And now we're finding out how important the gut is to our immune system, how important the gut is to our mood, our brain function, even to the inflammatory response and a state of inflammation, pro-inflammatory state. So taking care of our gut is very important, and we're going to touch on that very briefly as we move through. Indeed, we are fearfully and wonderfully made. So as we think about this immune system that is so powerful, there is no way we could discuss all the benefits and the powers and the abilities of the immune system in this short time. But what choices will we make now as we think of the immune system? What will be the trajectory to holistic self-care? How will I take care of myself? What will we choose? I'd like to share one quote, and it says, pure air, sunlight, abstemiousness, rest, exercise, proper diet, the use of water, and trust in divine power. These are the true remedies. All need to become acquainted with that most wonderful of all organisms, the human body. They should understand the functions of the various organs and the dependence of one upon another for the healthy action of all. This was intriguing to me as I thought of the gut interacting with the brain and interacting with the mood and interacting with the immune system. Psychoneuroimmunology. They should study the influence of the mind upon the body upon the mind, and the laws by which they are governed. Let's look at some of these principles that we can integrate in our lifestyle. And so we want to increase our intake of fruits, nuts, grains, and vegetables. Apart from increasing nitric oxide, which will help your blood vessels be more flexible, it increases serotonin levels, which can help you to feel happier. Yes, and if we're happier, we will have less inflammation in our systems. These foods are also rich in antioxidants and phytochemicals. And it was very interesting that the wellness food and supplement data of 2021, in data collected 2021, shared that coenzyme Q10 is also a powerful antioxidant that you can increase your intake of to reduce inflammation and protect your immune system. Also, selenium is another substance that you'd want to increase your intake of, and zinc, and of course, curcumin, quercetin. Interestingly, we want to reduce our intake of animal products and processed foods. Eat foods as grown as much as possible. Say no to the Western diet. Studies are showing that persons who ate more of the Western diet had a greater risk of illness during the COVID-19 period. Say no to the Western diet. Choose anti-inflammatory foods instead. And just going back to the gut, 80 to 90% of our immune system sits right there in the gut. So diversity in the gut is most crucial. Fruits, nuts, grains, and vegetables actually. Diets high in red and processed meats, sweets, desserts, and French fries, refined grains are associated with a higher pro-inflammatory state. So we have an increased production of C-reactive protein and interleukin-6 and those pro-inflammatory cytokines present. In one study where the study group was given a breakfast high in saturated fats, and their interleukin-6 levels were assessed before and after, it was found that 10 hours after that breakfast with high saturated fat, their interleukin-6 levels were twice as high as before, compared to the control group. Another thing we want to focus on is eating so that we can control any excess adiposity. 30% of interleukin-6, which is pro-inflammatory, actually comes from adipose cells, which will promote chronic inflammation. So we want to work to reduce adiposity as much as possible. Now, quite fascinating is what Frosto, Forsyth, and Keshavaran and Voigt in 2021 have shared, that the brain, the microbiome in the gut is crucial for that interaction is crucial for the maintenance of a healthy immune system and reduce inflammation. Diets containing large quantities of saturated fats, trans fats, refined carbohydrates, in addition to limited intake of fiber and alcohol, are associated with cognitive dysfunction, while conversely, diets low in those elements mentioned and high in polyunsaturated fats, or the good fats, high in fiber and high in polyphenols, are actually associated with better cognitive function, memory, and gut function. The diet is considered to be the single greatest factor that influences the intestinal microbiome, the germs in the gut. As we mentioned before, diversity is crucial. So the diet robustly influences the types and function of gut germs. Your gut germs are specific to you, and my gut germs, they're both signatures. So we need to eat a variety of foods as close as grown, fruits, nuts, grains, and vegetables, so that we can maintain that diversity in our gut microbiome, which will help to reduce inflammation and keep our immune systems well. It also will help to keep an intact gut lining and prevent what we call leaky gut, preventing the movement of harmful bacteria and germs into the system, or toxins into the bloodstream. This has been found to increase our risk when we have a leaky gut situation, increases the risk of Alzheimer's disease and other inflammatory diseases such as asthma, depression, and other conditions. So neuroinflammation is what we really want to reduce, but it also interacts and causes inflammation. It also impacts our brain and our mood. Now that's interesting that God told us in Genesis 1:23 and chapter 3 verse 18, from the beginning, the best foods to eat. Increase our intake of the fruits, nuts, grains, and vegetables, and add veggies. They also definitely are for the service of man. Now, in addition, we want to talk about exercise. Exercise actually enhances immune competency, and it increases interleukin-6, which we say is pro-inflammatory, but it's only transiently. In that little space of time, it has been found that tumor necrotic factor alpha is reduced, and interleukin-10, which is anti-inflammatory, is increased. So exercising will cut down on inflammation. This is wonderful news. Even if we just exercise for 30 minutes, you might not have time. You could probably use 25 minutes with high-intensity interval training of increasing the heart rate, cooling down, even with 3 applications of that intensity cooling down. But just do some exercise, get active, so that we can reduce our inflammation, our state of inflammation. Regular physical activity, frequent structured exercise reduces the incidence of many chronic diseases and also suppresses inflammation and promotes immune competency and regulation. We also realize, and this was interesting, according to Dalton, Mermier, and Zool 2019, that exercise improves the gut microbiome. Exercising actually increases the good flora, the germ, the diversity of flora in the gut, and maintains and stabilizes those tight junctions that we want to keep tight so that toxins don't pass through to get into our bloodstream. Quite interesting. So exercise some more to keep that gut diversity going. Greater gut diversity will definitely improve the function of our immune system. Yes, and laugh. Yes, laugh. That's internal jogging. It stimulates your organs, improves the immune system, improves teamwork, and reduces conflicts. Definitely we want to laugh some more. Laughter, we're encouraged, can improve the immune system even up to 24 hours. So laugh, soothe that tension. I would do well with some laughter right now. All right, and then you also want to quickly touch on water inside and water outside. Of course, drinking water, as long as you do not have heart conditions or renal conditions that will interfere with your water intake and your water balance, you can divide your body weight by 16, and that gives you a good idea of how many glasses of water you have for the day. But hydrotherapy has been found to increase white cell count. Hydrotherapy has been used even during this pandemic in chest fomentations, increasing white cell production and reducing congestion. Hydrotherapy has been very beneficial, and so we want to encourage you to use hydrotherapy. Sunlight. This is fascinating. Exposure to sunlight. Yes, someone mentioned vitamin D. Exposure to sunlight will cause the production of vitamin D as the sun, the UVB rays hit that skin. Of course, our complexion will differ. So persons with a lighter complexion would need less time in the sun compared to persons of a darker complexion who may need up to 45 minutes. The issue is just ensure that you don't burn. But what I want to focus on is that the vitamin D, nuclear vitamin D receptors are on all our T cells and B cells. I found that to be so fascinating. So when calcitriol is available in our blood, it actually binds to vitamin D receptors on these cells. The vitamin D receptors are on T cells, B cells, neutrophils, monocytes, and dendritic cells. So we can see the big benefit. The vitamin D increases antimicrobial peptides. And some of them are called defensins, beta-2, defensins, beta-4, catalycidin, antimicrobial peptide. All of these are produced more by macrophages, the monocytes, and many other cells. We won't go into all of those cells right now. But when the macrophages and monocytes have vitamin D connected to those nuclear vitamin D receptors on their surfaces, what we find happening is that they will do more chemotaxis, more autophagy, and more phagolysomal fusion, so they can destroy those offending organisms faster and easier. Now, when the vitamin D binds to the nuclear vitamin D receptors on our epithelial, intestinal, lung, and corneal cells, this reinforces the physical barrier function. So what we are seeing and saying here is as vitamin D binds to these nuclear vitamin D receptors on these cells that are barriers, the junction stays tight, protecting our gut, protecting our innate immunity. Getting sunlight is amazing. And so we are making getting more antimicrobial effects, which will increase our body's defense against microbes. I hope you take some more sunlight. If you're at home, at class, try to get the class in the sunlight. Maximize your opportunities to get that sunlight in. So we find that vitamin D will modulate the innate immunity, as we discussed. It also modulates the adaptive immunity because it helps to turn off excessive or a pro-inflammatory state. It down-regulates it. And so when we have the T helper 1 on their aggressive immune response, the vitamin D, calcitriol, actually turns them into more pro-inflammatory. So they will make more interleukin 12, interferon gamma, interleukin 9. Oh, these are pro-inflammatory, sorry. When the vitamin D binds to these receptors, what we have being produced are anti-inflammatory cytokines, like our interleukin 5, interleukin 4, and interleukin 10. And this is amazing. So vitamin D helps to down-regulate the pro-inflammatory state. And so in cases when we have all the cytokine storms and so on, vitamin D may play a very good role in suppressing the pro-inflammatory state and that pro-inflammatory, anti-inflammatory war to cool down the immune response, like your T suppressor cells. Just jumping to ear very quickly. We want to take deep breaths. I hope you're not crouched over where you are. I do hope you're sitting up and that you're expanding your lungs as I ask you to inhale with me. I hope you're sitting by a window getting that fresh air, or if you have a plant. It's very important to have plants and trees near to your home and plants on the inside. Get beside some waterfall when you can, or anywhere with moving water. This is the time when negative is good. Air that we get from moving water is negatively ionized. And this actually, as it interacts, as this negatively ionized air interacts with what we call phytonicides. That means plant killers, plant warriors. As the negative ionized air interfaces and interacts with the phytonicides released from the plants, they actually can help to destroy microbes in your environment. They act directly on the innate immune system, the phytonicides, and they have been shown to increase the level of natural killer cells. So get that fresh air, get those plants in your home, get your English ivy, get your areca palm, get your snake plant, put them in the home to absorb those indoor toxins, and get outside more and get more of the negative ions. So this is one time negative is good. Negative ions actually improves the immune system and helps to balance out or suppress pro-inflammatory states, pro-inflammatory, anti-inflammatory wars. It tends to quench those situations and stabilizes the autonomic nervous system, and also improving your blood flow, because of course it will promote relaxation and more serotonin will be produced, which is also helpful for the immune system. Deep breathing of that negatively ionized air, very, very important to promote our immune function. And we're moving through quickly. Another thing we want to highlight is getting enough rest. It's been found that disturbed sleep has been found to promote those pro-inflammatory cytokines like interleukin 6 for at least 24 hours after we have lost that, sleep. So it's important to get enough rest. Insufficient sleep has been found to increase risk of weight gain and obesity, and we already mentioned how obesity can increase a pro-inflammatory state. We want to avoid that. Get your rest. And we know how it can be. Late at night, when ghrelin is secreted, when we should be asleep, ghrelin is secreted, and definitely we think we have to have a big meal. I'm hungry. That's the time that we should be in bed. And that is really, it increases our appetite and reduces our ability to say no. It's best for us to eat earlier in the evening and leave that heavy meal for breakfast. Very important to improve your sleep quality so that can improve our overall health. So getting enough sunlight in the morning will help us to make serotonin. Eat foods that are rich in tryptophan is also very helpful for the gap junctions in our gut, maintaining our gut microbiome and also protecting the gut so that toxins will not get into the system. Find some time to exercise. That will help you to rest better. Avoid sleep robbers at night. Make sure you're sleeping in the dark. Put that phone on airplane mode so you don't have all that EMF disturbing your sleep. And we know it's probably very difficult for us as nurses in terms of shift work, but let's see if we can stick to a regular sleep schedule. That can be more helpful than a variety of changes. We know you probably cannot do a lot about that in our current situation, but just being aware and seeing how we can, if we're sleeping in the day, keep that room dark, quiet, and do what we can to promote the best of what we have. Of course, an empty stomach going to bed is one of the best. And finally, the most important tip that we can use to boost our immune system is letting all our anxieties and our fears and cares, leaving them to God. As we totally surrender and trust Him, it improves immunity. As we talk to Him, we've seen studies where prayer improves recovery from illness. Depression, stressful interpersonal experiences contribute to acute and chronic pro-inflammatory cytokine production. So we want to leave our anxieties at God's feet and let go of the depression. Depression and stress contribute to greater risk of infection, prolonged infectious episodes, delayed wound healing, all due to pro-inflammatory cytokines. And another thing we want to do, increase our connectivity with others. Lack of social support, social isolation, poor interpersonal integration, all of these have been associated with increased interleukin 6, which is the pro-inflammatory cytokine, and also C-reactive protein production. Let's connect, send that message, just Send one encouraging word or a thought to someone else. Reach out. But most of all, leave your anxieties at God's feet so that we can boost our immune function. A merry heart. The Bible is just right. The Lord is just amazing as he tells us these things way in advance of science discovery. A merry heart doeth good like medicine, but a broken spirit dries the bones. The hematopoietic cells are from the bone marrow. And so as we are happier, these cells in the bone marrow will thrive even better. A merry heart maketh a cheerful countenance, but by sorrow of the heart, the spirit is broken. And be grateful. Find something to be grateful for. To be grateful, you to type in the chat something you are grateful for. Better is a dinner of herbs where love is than a stalled ox with hatred therewith. So be grateful. Be cheerful. Choose to count your blessings even when the challenges are high. And give everything to God as we choose to take more deep breaths in the fresh air and eating more fruits, grains, nuts, and vegetables, getting better rest at night undisturbed, and eating those things that will boost our immune system. So the intent of this presentation was to resensitize us to the power of the immune system. Of course, it could not all be covered here. Often it's undervalued, but hopefully we will choose to nurture it as we use principles that will help us to experience and use, yet to care for ourselves in a holistic way. And I do wish, above all things, that you prosper and be in health, even as your soul prospers. Thank you.
We certainly want to thank Mrs. Miller for such an informative and educational presentation. And I hope that whatever she has said to us, we will take heed and work with most of what she said, if not all. So our second presenter is Mrs. Sandra Lauren Chisholm Ford, who is a registered nurse, registered midwife, and public health nurse, and who currently lectures at the UWI School of Nursing Mona campus, where she also obtained her Master of Science degree in Nursing Education. She is a charter member of the Omega Kappa chapter of Sigma and the Kiwanis Club of Mona. She has also membership in various professional organizations, including the Caribbean Network of Nursing and Midwifery Educators and the Nurses Association of Jamaica. Mrs. Chisholm Ford is a member of the Women's Health and Gender Equality and is currently, she is a member of the United Nations mission to Haiti in 2011 and has a passion for women's health and gender equality and is currently pursuing a master's in philosophy, a PhD in gender and development studies. Aside from her talents and advocacies, Mrs. Chisholm Ford has also authored and co-authored several publications. This afternoon, Mrs. Chisholm Ford will be presenting to us on the topic infection control in the community. Please welcome Mrs. Chisholm Ford.
Thank you very much. Thank you for that gracious introduction. Thank you for having me. Thank you. So today we're going to be looking at infection prevention and control practices during COVID. And of course, it is very topical because as nurses, we still have to maintain our community health practice and offer the same quality service that the clients were accustomed to pre-COVID, but ensuring that we are maintaining our safety as well as the safety of the clients and their families. So just a little refresher, COVID-19 is spread mainly from person to person in close contact with each other, and it is spread mainly through respiratory droplets produced when an infected person coughs or sneezes. It is also spread by the uninfected person touching a surface or object with the virus on it, and it is spread when it is picked up on hands and then transmitted by touching the face, the mucous membrane of the eyes, nose, and mouth. As the COVID pandemic evolves, of course, as public health practitioners, we have to evolve to meet the changing needs of the community. And we must realize that prevention, that COVID-19 recognition and prevention must not prevent our routine and necessary patient care safety quality programs. We are content that we, as healthcare workers, must visit homes and communities. And with that, we should maintain work health safety. We should maintain adequate supplies of appropriate PPEs. And of course, when we're visiting the homes, we should have hand sanitizers to protect ourselves from COVID as part of our work health and safety obligations. Going again, ensure that when you're going out into the communities, have these things with you: your appropriate PPEs and your hand sanitizers. In the homes, we must be mindful that these services that we offer in the homes must be modified in order to ensure that there is minimal exposure or impact to either the client or the nursing staff. Additionally, healthcare professionals must, let me go back. We must monitor ourselves. If you are not feeling well, do not go to work. That's the first thing I'm going to say before we go any further. So monitoring your own health helps us to ensure that the people you love and care for are protected as well. It's not only about the patients that you're going into the homes to see, it's also about the persons that you share living quarters with. It is difficult to distinguish between the symptoms of COVID-19 and the symptoms of flu and the symptoms of cold at this time because the symptoms overlap. However, if you are experiencing any flu-like symptoms, err on the side of caution. Do not say, I know it's the flu. Yeah, you may know it's the flu, but still err on the side of caution and do not interact with anybody else. Stay away from others. In other words, self-isolate, even if your symptoms are mild. And this is just a reminder of what some of the symptoms are. And these are not exhaustive. There are others that you could add to this list. We have fever, we have cough, we have shortness of breath, we have sore throat, headache, loss of smell, loss of taste, runny nose, muscle, joint pain, diarrhea, nausea and vomiting, or loss of appetite. Of course, you're out in the community, we must have our hand hygiene moments. Going out into the community, there are several things that the staff must take with them. You must take hand sanitizer, you must have liquid soap and running water and disposable towel. I did not add that here, but you can add it to dry your hands. And many persons will ask, how do I get running water? How do I take this with me? Of course, you will take a gallon bottle or a half-gallon bottle of water, which you will ask someone in the community to pour for you. So that will be your running water. Also, when delivering care in the community, there are 4 main hand hygiene moments. The 4 main moments are immediately before you enter the client's home, before you touch the client, after you touch the client or any surface within their home, and the final moment is immediately after you exit the home. And let me say, as a public health nurse, you do not use sanitizer more than 3 times before you wash your hands. Let me restate that. After 3 uses of the hand sanitizer, you should wash your hands at any given time, ordinarily. So I see people sanitizing back and forth, and they take the sanitizer out of their pockets and they sanitize their hands and then they put it back in their pockets. And you're infecting and reintroducing microorganisms to those pockets. So make sure that you take your running water with you and you wash your hands if you have water. So I see sometimes students will want to use hand sanitizers while in the clinical area. That is not allowed. You use sanitizer in that case in the absence of running water. If there's running water, you do not need to sanitize. Always choose hand washing as your first hand hygiene opportunity. Of course, when you are going out into the community to give care, the institution or organization that you work with must have policies and procedures that are there to address any unforeseen circumstances that you may have within or you may experience within the facility or in the community. There must be a team lead. And the team lead is the one who will be responsible for managing and coordinating any response that we will mount as a result of those unforeseen challenges. We will also be able to, the organization should also be able to identify who will talk to the client and who will inform the client about any changes that need to be made in their care. The organization should also keep a record of the staff members who have contracted and recovered from COVID-19 vaccines. We must encourage and promote the flu vaccines at this time, as well as keep an up-to-date record of the staff immunizations. Staff should understand, and I expect that all of us should at this time, how COVID-19 is transmitted. Therefore, we should use standard precautions when caring for clients with undiagnosed respiratory infections. That means they have a respiratory infection, you don't know what it is clearly. So therefore, you use your standard precautions for these infections and any other symptoms that could be COVID-19. There again, you should err on the side of caution by using your standard precautions. Before you go out, you don't just pop up to the client's home. Even though you're going to be giving care, please be mindful that you're going into their personal space. You have to make contact with them before you go. So if you can't contact the client directly, you speak with a family member or close friend. And if you cannot go and you're going to ask them to come into a facility for care, you communicate that as well. You should also identify whether or not the family or friend is able to provide the assistance that they need, or if they will need the health departments to provide the services or make arrangements for the services to be given. If there is any reason why we cannot go into the homes to give the service that they require, they should be informed. So let's say we have flooding, similar to ones that we had recently in St. Anne and St. Mary, or any other natural disaster that may cause roadblocks or so on, you need to communicate. You also need to identify whether the client has the support of friends, if they need to do any shopping or if they need to collect medication or so on to manage their condition. What are standard precautions? These are infection prevention practices that are used in the healthcare setting. So what are they used for? To perform hand hygiene before and after each episode of contact with the client. You must safely dispose of sharps, and you must routinely clean the environment as well as sanitize any reusable equipment. You should also conduct and encourage respiratory hygiene and cough etiquette. And still in 2022, with all the information going around, people still do not practice or are aware of what is proper cough etiquette. And we should remind persons that they do not cough into their hands, they cough into their elbows, or they cough into a tissue and they dispose of same, and they should always wash their hands after they are disposing of these used material. They should also avoid touching where possible, and whenever there's a risk of spreading the disease, they should also make sure that whatever waste that comes from the home after the home care service is offered, and whatever linen that needs to be disposed of or recycled should be managed appropriately. And of course, personal protective equipment that is in contact with large amounts of blood and bodily fluids should be disposed of according to the Ministry of Health's infection prevention and control policies. And for this setting, it includes all body secretions, urine, and so on, blood, and we do not include sweat. If the client has any break in their skin as well, they should always wear their PPEs. Any contact with, if the healthcare professional is expecting to be in contact with any droplets, they should also implement droplet precautions, and they should also understand that contact and droplet precautions include the proper donning and doffing of PPEs, and it also may include the putting on of protective eyewear. If there is the need for PPE, the staff must use new PPE for each episode of personal care. So it means that you do not use the gowns and gloves and you put them down and say, okay, I'm coming to see you tomorrow, Mr. Brown, so I'm going to use this tomorrow when I come to see you. No, that is not allowed. Every time you're going, you use a different set of PPE. You do not reuse the same PPE for the same client, nor do you reuse for other persons in the home. If there are more than one person in a different space, then you change it. If you're in the hospital and you are offering hospital care, you are allowed to wear the same PPE, but not when you are working in the home. Eye protection, of course, that's the only PPE that may be reused, but it must be cleaned thoroughly. And of course, hand hygiene must be performed before and after contact with your clients. Putting on and removing your PPE must be done before you enter the client's home. Putting on the PPE, You put the PPE on before you enter, but of course you must wash your hands before you start putting it on. Make sure that your hands are clean so you do not contaminate yourself while you are donning. You should remove your PPEs in the same way that they are, in the opposite direction, the way they are put on, so that you prevent contamination of your hands and clothing as well as the environment. And you should wash or sanitize your hands between the removal of each item of PPE. That's just a little bit different in the community. You sanitize in between the removal of each piece of PPE as soon as it is removed. And I will tell you a little later how this is done. You, of course, must dispose of your PPE safely. So your gloves, your gowns, and masks must be disposed of in infectious biohazard waste bags. And if you don't have biohazard waste bags, you can use the regular garbage bags, but you double bag. So you place it in a disposable bag, then you place that bag within another bag, and you tie this securely and return to the healthcare facility for safe disposal. And of course, you wash your hands or sanitize between touching each bag. This is required when you are in the community, in the client's home. Disposal of your waste. Personal waste, such as your used tissues and the client's used tissues, not yours, the incontinent pads, other soiled items, disposable washcloths, these should be disposed of also in infectious biohazard waste bags. And of course, there's nowhere in the community to dispose of these, so these are returned to the healthcare facility for proper disposal. Some clients in the homes, especially if they're diagnosed with asthma, they may need to use aerosols, such as nebulizers or so on, or some medications that are given may be required to be given as aerosols. You'll need to be mindful of the use of aerosols while in the client's home, because this increases the risk of the virus being spread into the air, because when the aerosols really mystifies the particles and it is spread further, and it could be another source of infection. So clients who use nebulizers and CPAP machines in the community, you have to be mindful of that. So if you're going into the home to visit, you need to be mindful and ensure that the CPAP machine is turned off at least an hour before you come in, and the windows are open so that the air is dissipated before you go in, or you could see the client in another room of the home if that is possible. We also would advise that you use a spacer if that is available. You should never use nebulizers for persons who are suspected of being COVID-19 positive. And this is what I just spoke about, how to ensure that you ensure that the aerosols from CPAP or nebulizers are dissipated before you enter a room. Cleaning is also important, and you encourage the family members or caregivers to clean properly, and you will instruct them how to do so. So you will educate them how to properly clean using the usual household products, and this is generally or 1 in 5 or 1 in 10 bleach solution. So surfaces that are frequently touched should be cleaned with detergent or disinfectant wipe several times a day, and also if visibly dirty or soiled. So you know that the removal of the virus that causes COVID-19 requires thorough cleaning followed by disinfection. So it's a 2-step process to remove the COVID-19 virus. Of course, of note, the 2-step cleaning process requires that the physical cleaning with detergent followed by disinfection with a chlorine-based product. And of course, emphasizing again, cleaning is essential. It makes no sense you try to disinfect a soiled area. Cleaning reduces the soil load and allows the disinfectant to work. So I see sometimes persons may, even in our own homes, if we have a dirty area, we will just throw the bleach on the dirty area and then we clean it up. That is not a thorough cleaning. You must remove the soil first and then you disinfect after. The bleach will not kill a virus if the surface has not been cleaned with a disinfectant first. So, minimizing our risk in the community, we must do the following. We must limit touching of surfaces and equipment. We must change our gloves when torn or visibly contaminated. We must perform hand hygiene properly. We must remind our clients of the need to regularly clean any equipment that is frequently used, as they will become contaminated with the COVID-19 droplets. We should also remind our patients or clients of the need to perform regular hand hygiene. But there may be a time that we may need to transport our clients for whatever reason. Client's condition may have worsened and they need to be transported to hospital, or it's just a routine transportation for a routine check. We need to determine the number of healthcare providers who should travel together in the same vehicle. You should minimize the crowding in the motor vehicle. We must ensure that the principles of hand hygiene and the bag placements and seating arrangements and airflow, all of those should be observed and practiced while transporting clients. And we must ensure that before entering the vehicle, both the driver and passenger should perform hand hygiene. And usually it's with the alcohol hand rub, but as I said before, if you have running water, please ensure that this is your method of sanitation. Before transporting the clients with suspected or confirmed COVID-19, you must perform a risk assessment. You must note the type of vehicle that you require, and it's preferably a vehicle that will separate the client from the driver. You must determine the physical capability of the client and if they will need any assistance. And you must be able to determine the ability of the client to wear a surgical mask so that they can minimize the spread of the droplets. And you need to ensure that the client should be able to practice respiratory hygiene. If the driver does not have any direct contact with the client within the vehicle, you should have the driver use droplet precautions. If the driver will be directly in contact with the client, the driver is to use both contact and droplet precautions. And we should ensure that all handbags are placed on the floor and not on the seats. That's if they are small. But if they are very big, like some of us love to walk with a whole bunch of stuff, they are placed in the overhead compartment. The passenger should sit in the back, diagonally opposite from the driver as far as possible. Whether or not the passenger has respiratory symptoms, mask wearing is mandatory. So it's not an option. So the client can say, but me not cough, me not sneeze, so I don't need to wear a mask. Mask wearing is mandatory. You are to ensure that hand hygiene is performed by everybody who is entering that vehicle, and the client is educated regarding respiratory hygiene. And the client should be provided with a plastic bag with tissues and a alcohol hand rub so that they can perform hand hygiene after they have done their respiratory hygiene. The driver is to wear a surgical mask as well and protective eyewear if he's going to be in direct contact with the COVID-19 client, and they should be using it when providing direct assistance to the passenger performing hand hygiene before assisting the passenger, before entering the motor vehicle, on exit from the motor vehicle after providing assistance to the passenger, as well as after dropping the client off and returning to the motor vehicle. The airflow in the vehicle is also important. It is best to use outdoor air. If the ambulance is one or the vehicle is one that separates the driver compartment from the passenger compartment with a glass, well, that's fine. But sometimes the air recirculation happens through the air conditioning vents. So it is best to utilize outdoor air and switch off the air conditioning. So the suggested donning sequence is you put your glove on. You perform your hand hygiene first, then you put on your apron or your gown, you put on your mask, your eye shield or face shield, and then your disposable non-sterile gloves. Your suggested doffing sequence is you're removing your gloves first, then you perform hand hygiene. Remember, in the earlier part of the presentation, I did mention that hand hygiene is to be performed after removing each item of PPE. So this is how it goes. You remove your gloves first, then you perform hand hygiene. Then you remove your apron or your gown, then you perform hand hygiene. You remove your eye protection or your face shield, then you perform hand hygiene, and then you remove your mask last, then you perform hand hygiene. So, of course, we should note well that hand hygiene must be performed before bringing hands to our face, and we all need to remind ourselves of that because we have a tendency to unconsciously put our hands to our faces. And of course, all of these activities will produce waste. So the management of waste are done according to the Ministry of Health's protocols. And it suggests that clinical waste should be disposed of in biohazard bags, or if you do not have them, you double bag your waste and return it to the facility. All non-clinical waste, such as the things that the client uses at home, their own things, can be disposed of in the general waste stream. And the PPEs is considered general waste unless contaminated with large amounts of blood or bodily fluid. However, the suggestion is they're your PPEs, you took them there, you take them back to the healthcare facility with you. And of course, we know that our sharps will definitely be going into our sharps bins. And this is my presentation, and I will now entertain questions if you have any. Are there any questions in the chat?
Any questions for Mrs. Chisholm-Ford?
Somebody's asking, why aren't we to wash our hands after we sanitize 3 times? You must have misheard me. I said you should. You should wash your hands after 3 sanitizers. That is the World Health Organization's required standards.
Okay, any other questions? All right, well, if there are no further questions, we just want to thank Mrs. Chisholm-Ford for that very informative and practical presentation. Thank you very much.
And thank you very much for having me.
You have wipes?
Okay. All right, so Ms. Miko, seem to have lost Ms. Miko. Our next presenter is Dr. Cheryl Thomas. Dr. Thomas is a licensed clinical psychologist, researcher, and experienced educator with over 18 years of practice providing treatment to adults, children, and families. Her area of expertise includes psychological assessment, diagnosis, and treatment of various disorders, to include post-traumatic stress disorder, PTSD, anxiety disorders, depression, autism, ADHD, among others. Dr. Thompson's experience as an educator spanned over 15 years at the university level. She has taught in Texas Southern University, and she is currently an associate professor at Northern Caribbean University. Dr. Thompson is a founder and director of South Central Treatment and Wellness Center, a private practice specializing in trauma-informed treatment and care. She's a certified supervisor for early career psychologists and for master's and PhD students completing practicum and internship requirements. She's a member of the American Psychological Association, APA, the Jamaica Psychological Society, and the International Honor Society in Psychology. Without further ado, please help me to welcome Dr. Cheryl Thompson.
Good afternoon, everyone. You guys hearing me okay? Hello?
Yes, we're hearing you. I'm hearing you.
Okay, great. It's great to be here. I want to thank the administration for the nursing department for inviting me. And I'm going to share my screen. Just give me a moment to do that. And I've been enjoying the presentations so far, and I'm also learning a lot. Mrs. Miller spoke earlier about self-care, and much of what I have to talk about has to do with taking care of our minds, our bodies, our spirit. And we find that the same behaviors, activities, self-care, practices that we use for physical health is also beneficial for our mental health. All right. And are you guys seeing my screen?
Yes, we are.
Okay, great. So we're going to take a few minutes to look at how do we cope in unprecedented times? How do we manage? What are some things we can do to build resiliency? And the question is asked, what is resiliency? What does it mean when we say that we're resilient? So to be resilient, resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. And COVID-19 has been a significant source of stress for most of us, as we have to make changes to our, how we work, how children attend school, and how we interact with others. So resilience involves behaviors, thoughts, and actions that anyone can learn and develop. So even if you don't feel like you're a resilient person, there are things you can do to build that resiliency. There's a term that we use, bounce back, so that when you are faced with stress and challenges, when you feel overwhelmed, if you are resilient in your thinking, for example, there are thoughts that can help you to bounce back. There are thoughts that can help you to overcome and recover from those stressful situations. So being resilient does not mean that you won't experience difficulty, right? So you're resilient, you have been practicing your self-care, but we will still face challenges. We'll continue to face setbacks, uncertainties. And so there are times when you may feel more resilient than in other times. As a matter of fact, the road to resiliency is likely involved with considerable emotional distress. It says that, when we learn to deal with challenges as we overcome the trials and challenges that we face. So resiliency is not an all or nothing. You can be a little bit resilient, you can be a lot, you may be more resilient in some situations than in others. So it's basically doing the best you can in your current situation. When we look at our best, the best may vary from situation to situation. If you're overwhelmed and stressed and you're dealing with a lot at once, then your best may look different from someone from the times when you're feeling rested, refreshed, calm, and focused. So how do you build resiliency? What are some things that we can do to build our resiliency? And we're going to look at connections, wellness, and thinking. There are techniques that if you implement them, they can empower you and help you to withstand the trauma of some of what we're facing these days. And one of the first things we want to do when we think about building resiliency, being able to cope with the changes that we're seeing around us due to COVID-19 and other challenges that we're facing. One of the things we want to keep in mind is that it's important to connect with others and keep your connection. COVID in the first part of the pandemic did separate us. So we had a lot of folks who used to go out and connect with family members who were not able to see those family members. And so they probably turned to the social media as a way of connecting. But connecting with others is important to building our mental health and for building our resiliency. The other thing we wanted to think about, and I think Mrs. Laddie Miller talked about this earlier, is to take care of your bodies. Self-care is essential for building resiliency. If you get too caught up in doing everything else, taking care of everyone else and all the other responsibilities that you have, then at some point you're going to find yourself running into burnout. You're going to feel like you don't have enough energy, you don't have enough fuel, you don't have enough to give because you weren't taking care of yourself. So it is critical that we practice proper self-care. Spiritual practices are also important when we think about building resiliency, because prayer and meditation, I think someone's mic needs to be muted. So spiritual practices of prayer, meditation can also build our connection and restore hope. The fact that you believe in a God who's all-powerful can be a support. It can be therapeutic if you're practicing the spiritual you're engaging in spiritual practices. You're praying, you're reaching out to fellow believers, you're connecting with others. So what are some of the coping skills that you can try? One moment, let me turn this off. What are some coping skills that you can practice in terms of building your resiliency? The first thing you want to do is to examine your life, because sometimes we have been working under so much stress for so long, we don't recognize that we are overwhelmed, that our bodies are in a constant state of stress. So it's important to examine and ask yourself, if it's hard, are you finding it difficult to make time to relax? Are you finding it difficult to set some time aside for your me time? And in doing that, it'll help you to know your limits. So don't bite off more than you can chew. Learn to say no. So sometimes we have work responsibilities. We have responsibilities in the church. We take on responsibilities in the community. And before long, we have no time for ourselves. We have no time to take care of ourselves, to take care of our bodies, to sleep, to get enough sleep, to eat right. And so if you find that you are neglecting your self-care, then it may be time to say no and allow someone else to pick up where you are not able to help out. Develop relaxation skills. And I have an exercise at the end of my presentation. What I may do is to just copy the link and paste it in the chat so you can use the exercise at different times. So manage your body's response to stress by relaxing, learning to relax. One of the things that we've noticed that has helped with relaxation is music. So choosing the right type of music at the end of the day, instrumental piano, saxophone, jazz, music that will help to change the brainwave can help us to relax. So even if you're not able to attend the gym or do something outside the home, you can put the music on, keep it in the background as you're fixing dinner as a way of helping you to relax. Engage in enjoyable activities. So you watch a movie, listen to music, as I mentioned earlier, going to the beach, standing outside. I think someone mentioned earlier about standing outside and just looking at the greenery, looking at the trees. All of those we've found to be therapeutic and can help us to unwind, to relax, and inadvertently to build our resiliency. So you can prepare your body to cope with stress by getting enough sleep. And I'm just reiterating what Mrs. Miller mentioned earlier. Meditation, making sure that your diet is nutritious, exercising regularly. And of course, I think we all know by now that exercise is not only good for mental health, but it's also preventative. When we exercise regularly, we find that we prevent some of the conditions that we may develop when we're not exercising. And of course, regular checkups. So don't be so busy that you can't take care of your needs, your physical needs and your mental health needs. You shouldn't be so busy that you can't find half an hour 3 times a week to exercise. If that's happening, then it means you need to reassess what's going on in your life. Sometimes when we get so busy and stressed, our self-care goes on the back burner. We think, well, I'm too busy to sleep well. I'm too busy to exercise. I don't have enough time to eat a proper meal. So you kind of push those to the back burner. When things have settled down and you're doing better and you're managing better, then you'll go back to the self-care activities. But it is those very things that's going to help you through this challenge. Whatever challenge you're facing, when you eat right, get enough sleep, those things can help you to manage the challenge and the stress that you may be facing. Expand your social network. So we've found that social support, even if you're not actively using the social support, just knowing that I have friends, I have families, I have individuals that I can call, that I can talk to, can be therapeutic. Prevent burnout. And earlier I was talking about not placing your needs on the back burner. So don't rush yourself, don't push yourself beyond your limits. If you need to, delegate responsibility. Have others help you. If there are people in your life So maybe you are a mom with young children and you have grandparents, aunts that are willing to help. Use the support. Use it because you need the support and the help to manage and to build your resiliency. Now, one of the things that we've also found is that we tend to do better when we understand the stressful situation. We tend to do better when we understand what is going on, when we know what to expect. And what we're finding is that there are so many uncertainties about COVID-19. So folks are just looking everywhere for information. Some of the information may not be correct, but it's information. So we're looking for information to help us to understand, because when we understand the situation, then we can better prepare ourselves to deal with whatever that situation is. Don't keep upsetting feelings. So maybe you're nervous, or maybe you are sad, maybe you're feeling depressed. The first place to start would be to speak to a friend, speak to a family member, to see if maybe by sharing and reaching out to someone, you can help to alleviate those feelings. You can also write in a journal. Sometimes by writing and expressing your feelings in a journal, it helps to alleviate, it takes some of the pressure off. But if you're still struggling, then you may need to speak to a professional. One of the things you can do as a family is to take time to talk with the family while you're eating. So don't rush through. I know there are times where, mom is having dinner in the kitchen, the children are in their rooms eating, the husband is somewhere else. May use that dining time, that time that you eat, to spend time together, to take a moment to just connect and talk to each other. Accept change. And sometimes this is one of the hardest things to do. But accept that change is a part of life. There are certain goals and ideals that may no longer be attainable as a result of adverse situations in your life. Maybe you had plans to move overseas before the pandemic. Maybe you had plans to do different things. But because of the changes that are happening around us, then you have to shift and look at the goals that you have and, be flexible in how you go about achieving those goals. Manage your thoughts. It's important to keep things in perspective, because how you think will and can play a significant role in how you feel and how resilient you are when faced with obstacles. So if you are seeing everything as falling apart, nothing is going to change, everything bad is happening, there's nothing going on good in my life, then that will definitely affect your resiliency and it'll affect your mental health. So even though you don't understand everything that's happening, you do know a God that understands and is still in control. And so you can talk to him about the things you don't understand and trust that he's going to bring us through. So you want to replace stress-inducing thoughts. There are some thoughts that if we keep dwelling on those thoughts, we can develop mental illnesses. It'll make symptoms, whether they're physical or mental, worse. Right? So the things that you're saying to yourself, I'll never get through this. Nothing is ever going to change. Those thoughts are self-defeating and they won't help you. But you can change your thoughts. I will get through this. God is in control. I refuse to worry. When I use self-talk in treatment, I have the clients say the same 3 affirmative statements for about 2 weeks, because what we're trying to do is to replace some of the negative thoughts that they may be having. We do understand that we learn through repetition. And so by repeating those thoughts, at some point, your mind will grab onto it as truth. So be careful of what you focus on. Be careful of the thoughts that you allow to run through your minds. Sometimes you may feel like the thoughts are in control. I can't control them. But you can control them by replacing them with positive affirmative statements. What are some activities that you can do when we think about building resiliency in the family? What are some things you can do? So if you have young children, you work, you teach, you practice at the hospital, but you still have a family and you still have to be concerned and care for them. One of the things you want to do if you're trying to improve resiliency in the family is to stick to a routine. especially if you have young children. Children learn and have a sense of security when there's a routine. They know that they go to bed at a certain time, they wake up at a certain time, we have breakfast at a certain time, and on Saturdays or Sundays we worship. Those types of routine help to provide some sense of security for the very young, and it helps the mental state for the adults because you know what's going to happen. We talked earlier about understanding the situation and knowing what to expect. So as far as possible, try to stick with a routine. You may also want to create a priority list for the family. So what are some things we're going to do daily? What are the priorities for the family and what are the personal priorities that you may have? The basics would be making sure you're getting enough sleep, right? So children sometimes are sleeping in class because they're not getting enough sleep. When the parents are asleep, they may be on their cellular devices or they're doing different things. We need sleep. Our bodies need sleep. And I know I'm preaching to the choir because you guys know this, but our bodies need sleep to repair itself. And in the repairing of the body, the mind, the mental state is refreshed. So we need to continue the basics. Stay in touch with family, as I mentioned earlier, and create a separate workspace. So if you're working from home, or maybe the children are attending school online, then it's important to create a space in the home where they'll go online to attend their classes so that at the end of the day, you can leave that workspace and go and attend to the rest of your activities. What has been happening is that the work and the personal space is kind of flowing together. The work and the personal life is flowing together, and folks are feeling overwhelmed because they're feeling like they're always at work. And so by creating a separate workspace, then you are actually setting boundaries. Some of the mental boundaries that says, when I walk in this room, I'm going to work. And when I close my laptop, my computer, and I exit the room, then that's the end of my works for the day. Some behaviors to avoid when you're trying to build resiliency: avoid negative outlets. So some folks will turn to drinking or drug use or other addictive types behavior that are short-lived, and they mask the symptom. They're like a Band-Aid, but they don't help you to deal with the challenges that you're facing. So you want to remain sober. You don't want anything that's going to impede your ability to think clearly. Yes, sometimes you're tired and you feel like, I just want to go to sleep. It's best to use some herbal tea than to consume alcohol. Focus instead on giving your body resources to manage stress, and the resources we talked about earlier: exercise, making sure that you're eating a nutritious meal, sleeping, connecting with family, reaching out to friends that you haven't heard from. When we reach out to family and try to encourage and lift their spirit, there's a benefit for the person who is doing so. So there's a benefit for me if I try to call my neighbor and check on him, because it also empowers and lifts my spirit. So there may be times when you need to seek help. You've done everything that I've talked about earlier. You're doing your self-care, but you still find that you're having difficulty eating. You've lost your appetite, or maybe you're eating too much. You're not sleeping, or you're oversleeping. There's some disturbance in your sleep. This may be a symptom of a mental illness, so you may want to seek professional help. If you find that you are constantly nervous and worried, so nervousness and anxiety, some of it is okay for us. You know, there are times when we feel a little bit nervous and anxious, and it's appropriate for that time. But if this nervousness is interfering with your ability to do your work, to take care of your family, to think straight, to drive to work, then you need to seek professional help. If you're having thoughts of suicide or self-harm, you're feeling overwhelmed and you're feeling, I can't deal with this, it seems like things are getting worse in the society, I just need an out, then you need to reach out to someone, because the suicidal thought has been linked with depression. And much of what I'm talking about here is anxiety and depression. So if you find that you're having suicidal thought, or maybe it's a family member that's dealing with suicidal thought, or you're seeing that they're harming themselves, then it's important to seek professional help. If you're seeing signs of frustration, stress, or anger, that is not getting better and it's actually interfering with your relationship with family members. So the relationship between your husband and your wife, or maybe you and your children, has worsened where you're not speaking to each other, or when you do, it's out of frustration, where you're not listening, you're just arguing, there's constant irritation, conflict, then of course you may need to seek professional help. Unusual increase in fear and anxiety, I mentioned that earlier. And of course, relational difficulties. So the pandemic has highlighted a lot of relational problems within families. Maybe they were there before, but because folks weren't spending so much time together, then it wasn't in focus. But now that we're spending so much time together, they're finding that they don't really like each other, or they can't exist in the same space. So if you're facing any of these situations that I'm mentioning here, then it's time to seek help. There's an exercise that I'd want us to do. I'm going to copy this and paste it in the link. I'd sent it earlier to Miss Joy. I don't know if she's on. But what I'm going to try to do is to play the audio, and if you guys can hear it. So it's actually a breathing exercise, and it's meant to help you because sometimes we don't know how to breathe properly. And the breathing exercise is critical when we're trying to relax, when we're dealing with anxiety, when we're dealing with stress. So I'm going to play the audio, and you guys can let me know if you can hear it.
We're not hearing.
Are you guys hearing?
No, we're not hearing.
Okay, let's see if I hear this. Okay, what I'll do, I'll put it in the chat, and then you guys can listen to it after.
Okay. Thank you very much, Dr. Thompson. Any questions now for Dr. Thompson? We'll take questions now. All right, well, there seem to be no questions. We thank you very much, Dr. Thompson, for this very informative and therapeutic presentation, which revealed to us how we can harness our resilience and, more importantly, when to seek help. Thank you very, very much.
You're welcome.
All right, so at this time, I'm going to hand you over to Mrs. Bent Burton, Natania Bent Burton, and she'll be doing moving the vote of thanks. Natania.
Good afternoon. Are you able to hear me?
Yes, good afternoon.
Yes, we're hearing you clearly.
Feeling gratitude and not expressing it is like wrapping a present and not giving it. William Arthur Ward. This afternoon, after such a splendid day, utilizing the theme, health research, informing the trajectory of nursing in the 21st century and beyond, I have neatly wrapped your gift and now present it to you. The French says merci. In Japan, it's arigato. The Spanish says gracias. Koreans say kamsamnida. In Patois, it's tenki. But coming to you from the cool, cool hills of Mandeville, we simply say thank you. Chairpersons Mrs. Violet Wright, Mrs. Aloma Lai, and Miss Advelo Miko, we thank you for your leading roles and being the captains that guided our ship safely to harbor. administrators, dean and associate dean, and representatives from Kettering Health, we appreciate your presence with us. Zara Lawson, your welcome was scintillating and very much appreciated. Mrs. Carol Williams, the spiritual manna, the underestimated dimension of health, the value of prayer was nourishing, and we were well fed, and we are very grateful. We promise to not show up spiritually empty. Warmest thanks, Dr. Jacqueline Whittle, our keynote presenter, for your global overview of mental health impacts in the 21st century, informing the future. We support your stance on mental wellness. Thank you also for your contribution to the needs of the Kingston campus. Mrs. Marie-Lise Smith, we appreciate your presentation on the state of professional development in nursing, implications for the future. Dr. Caroline Mclean, we are beyond grateful for enlightening us on the use of virtual simulation among senior nursing students in a tertiary institution in Jamaica. Mrs. Lati Miller, many thanks for your contribution, nurturing undervalued treasure, directing the trajectory of holistic self-care. Infection control in the community, presented by Mrs. Sandra Chisholm, is well needed in this pandemic, and for that we say many thanks. Dr. Cheryl Thompson, thank you sincerely for helping us cope in unprecedented times, tapping into resilience. Miss Braham, our head cook and bottle washer, along with Miss Staff and Mrs. Ferron, we will be forever grateful for your unfailing dedication and hard work to ensure today was a grand success. To the media team, CCNPR, Dr. Vigilance and the research team, indeed we are very grateful. We could not have achieved success without your unfailing support. Faculty, staff, and students of this noble department, we salute you for the participation, support, musical contributions, and dedication in ensuring this day was a tremendous success. And last, but certainly not least, to you, the attendees and alumni, this day could not have been what it was without your presence, support, and commitment to building nursing education. And for that and so much more, we say thank you, thanks, thank you. Have a wonderful rest of the afternoon. I now turn you over to Mrs. Violet Wright.